to join today's session, day 2. It's Oncology as on updates from ESMO 2025. And I would like to invite program convener Dr. Naresh Sumani sir. He's a Director Oncology and HOD Medical Oncology and SCG Cancer Center and Somani Hospital, Jaipur. It's over to you, sir.
Thank you, Geetika ji and Tarun Mathur and the entire team of the Horizon for conducting this fifth annual Oncology as on today updates from the ESMO 2025. This is our annual and regular feature, and we try to select the topics which are of the clinical or day-to-day practice for our patients and for our medical fraternity, that how they can impact on the treatment or the outcome for our patients. Now, today we have hematology and molecular pathology sessions, lung cancer sessions, and other sessions. And at this time, our women's team won the World Cup in the cricket. So rightfully, our first opening batsman is Dr. Ishita Gupta, head of the pathology at the HCG Cancer Center, Jaipur. He will be talking about the molecular profiling in the prostate cancer, when, how, and how much it is required, which are the group of the patient. So she will be giving the brief introduction or the new things which has come in the prostate cancer as far as the molecular concepts are concerned. And when I was trying to understand this topic, I was amazed to see that it is beyond the BRCA, or it is beyond the certain identifiable mutations. So many changes has come, and it looks like that it is not less than the lung cancer as on today. So without taking much of time, over to you, Madam Dr. Ishita Gupta.
Good evening, sir. Good evening, all esteemed faculty members and delegate. Thank you, sir, for giving this opportunity. I'm sharing my screen. Is my screen visible to everyone?
Yes, ma'am. Can you make
Thanks.
it on the full screen?
Yes, sir. So good evening, everyone. I'm briefly talking about molecular profiling in prostate cancer, that when, how, and how much it should be used. So as you're all aware, this is Western data, which shows that prostate cancer is the most common malignancy in males. The WHO recommends the prostate cancer grade grouping into 5 pathological grades. I would be briefly explaining all these grade groups. Grade group 1 comprises of Gleason score less than or equal to 6, which comprises only individual discrete and well-formed glands. Grade group 2, it comprises of Gleason score 3 plus 4, which is 7. It comprises predominantly well-formed glands with few poorly formed, fused, and cribriform glands. Grade group 3 comprises of Gleason score 4 plus 3, predominantly having poorly formed, fused, cribriform glands with few well-formed glands. Grade group 4, Gleason score 8, 3 plus 5, which includes 4 plus 4 or 3 plus 5 or 5 plus 3, with poorly formed, fused, and cribriform glands, or few areas lacking glands with predominantly well-formed glands. Grade group 5, which comprises of Gleason score 9 or 10, and it comprises of predominantly areas without gland formation, with or without poorly formed fused forms or cribriform glands. As you can see, this is normal prostatic glandular epithelium, which further converts into atrophic. Then there is the next step is prostatic intraepithelial neoplasia. Then it converts into invasive malignancy, where the glandular epithelium invades into the stroma. And then the next step is metastasis, in which the prostate malignant cells are seen into adjacent organs or lymph nodes. So conventional molecular progression model explains initially there is an environmental or inflammatory insult, which leads to PTEN loss, NKX 3.1 loss, or GSTP downregulation. Further leads to telomerase activation, RB loss, P27 downregulation, and RAS FF1 downregulation. In the most advanced stages, we usually see P53 mutation or loss, loss of E-cadherin, and androgen receptor independence. There are other alternative mechanism models also, which includes P53 mutation, gain of function, NKX 3.1 haploinsufficiency, loss of androgen receptor, AKT activation, AKT de-addiction, and epithelial mesenchymal transition model. This is a schematic representation of most common 8 prostate cancer molecular classification, including epithelial-defined classification, immune-related classification, Tomlin's classification, multi-omics classification, PAM50 classification, and various other classifications. The histopathological classification, along with molecular alteration, divides prostate cancer into 3 major molecular subtypes. First being DNA repair deficient tumors, in which there is mutation in HRR genes, and these tumors are responsive to PARP inhibitors. Second being the androgen receptor-driven tumors, in which there is androgen receptor pathway alterations, which includes mutation, amplification, and splice variants. And third being neuroendocrine variants, which have distinct histopathology or biology, requiring alternative treatment approaches. Now, European Society of Medical Oncology stratifies prostate cancer into 4 different types of molecular subtypes based on actionable precision clinical management. First being, again, DNA damage repair pathway mutations, including BRCA mutation, BRCA1, BRCA2, and ATM mutation. These become the candidates for PARP inhibitors. Second being the androgen receptor pathway alterations, which includes mutations, amplifications, and these patients are candidates for androgen receptor targeted therapy. Third being MSI high or deficient mismatch repair pathway, and these are candidates for immunotherapy with checkpoint inhibitors. Fourth being PIK3K, AKT, and mTOR growth pathway dysregulation, and these are targets for combination therapeutic strategies. Why molecular profiling matters in prostate cancer? Firstly, prostate cancer has a global impact. It's the second most common cancer in men worldwide, with highly variable outcomes. Secondly, it helps in precision medicine by identifying actionable genetic alterations, driving progression and therapy resistance. Third, it helps in giving personalized treatment, tailoring therapeutic strategies, especially in critically advanced and metastatic disease stage. When to perform molecular profiling? First, it has a high impact in metastatic castration-resistant prostate cancer. Primary indication being patient in advanced stage to identify the targetable mutation. Second, in high-risk localized disease to enable proactive treatment planning. Third, in metastatic hormone-sensitive disease, which helps and guides in choosing the first-line therapy. Fourth, in clinical to assess the clinical trial eligibility in precision oncology trials. Various types of molecular profiling includes somatic tumor profiling, which analyze the genetic makeup of tumor cells themselves. Second being the germline profiling. This analyzes DNA from the blood or saliva and identify inherited mutations that may increase the risk for prostate cancer or other cancers in the family. Third, liquid biopsy. This analyzes the circulating tumor DNA in blood sample. Molecular profiling is done either through the NGS, liquid biopsy, or multimodal integration, which includes advanced imaging like PSMA PET for comprehensive assessment. Now, there are 4 pillars of targeted therapy of precision treatment in stage 4 prostate cancer. First being most common, PSMA targeted radionucleotide therapy. This helps in delivering targeted radiation directly to the cancer cells expressing PSMA. Second, DNA repair inhibitors, including PARP inhibitors like olaparib, rucaparib, niraparib for tumors with HRD deficiency. Third, anti-angiogenic agents. These targets tumor neovascularization, but these are currently under investigation in clinical trials. Fourth, immunotherapy. with the help of immune checkpoint inhibitors for MSI high tumor and neuroendocrine variants. PARP inhibitors helps in precision medicine in DDR deficient metastatic castration resistant prostate cancer, and they have 60% PSA response rate in BRCA mutated patients and 7.4-month median PFS improvement with olaparib. This is a schematic representation how PARP inhibitors work. In a normal cell with intact BRCA genes, the DNA damage is repaired and survived with the help of BRCA function. In a cell with BRCA mutation where one allele is only lost, the DNA damage is repaired and survived again with the BRCA function. However, in a mutated cell or in a cancer cell where BRCA mutation leads to both allele lost, in the presence of DNA damage, in the presence of PARP inhibitor, this leads to cell death. So there are principal classes of therapies investigated in metastatic castration-resistant prostate cancer. Like this, you are all aware how and when the single agent and combination therapies can be used. Various therapies which are used includes androgen receptor signaling inhibitors in metastatic castration-resistant prostate cancer, PARP inhibitors in DDR gene aberrations like ATM, CHEK2 mutation, BRCA1, BRCA2, immune checkpoint inhibitors in patients harboring MMR deficiency, PSMA inhibitors in prostate cancers expressing PSMA, and various other targets. PSMA targeted radioligand therapy is now a game changer in advanced metastatic castration resistant prostate cancer, as in this lutetium 177 PSMA 617. This is the dye which binds to PSMA expressing cancer cell, delivering beta radiation precisely to the tumor sites. Vision trial demonstrates significant improvement in overall survival and radiographic progression-free survival. This therapy is well tolerated with manageable side effects, and it has now it is increasingly available at specialized cancers worldwide. Molecular profiling is now indispensable for personalized treatment in advanced prostate cancer. WHO and ESMO frameworks provide evidence-based actionable molecular stratification systems. PARP and PSMA radioligands significantly improve outcomes in molecularly selected stage 4 patients. Molecular tumor board optimize patient selection, therapy sequencing, and clinical trial matching. And this expands profiling access, and novel target agents promise continued survival gains and improved quality of life in advanced prostate cancer patients. Take-home message from a pathologist point of view: with growing utility of NGS technology and increasing availability, the incorporation of molecular profiling in management of prostate cancer is now becoming a routine. A working knowledge of emerging molecular diagnostic is fast becoming a prerequisite for contemporary high-quality care for prostate care patients. Thank you.
Thanks, Dr. Isita, for the crystal clear presentation, and thanks for accepting the invitation the last moment also. Just a small question. In our clinical practice, how many times this simple BRCA, which we often do for the prostate cancer, you see positivity like 5%, 10%? Any rough estimation?
Sir, in prostate cancer you're talking, or all the
Yeah,
cancers?
prostate cancer.
Sir, whatever cases recently we have seen prostate BRCA mutations in the prostate cancer, like around 10%, I would say, sir, with all the cases we have seen at HCG.
So it is we have to accept as a clinician that BRCA positivity is always a possibility in the prostate cancer, and more NGS or whatever panel we can do for the patient, keeping in mind the logistic, I think we should do. including the comprehensive genomic profile to understand the correct picture and to utilize the newer drugs. Any question to Dr. Ishita Gupta from anybody? So if no, thanks, ma'am. And
Thank you, sir.
yeah, we move on to the next session by Dr. Abhishek Charan, who is a consultant medical oncologist working with me at HCG Cancer Center, Jaipur. Very enthusiastic, academic oriented colleague. So he will be talking about the few of the aspects in the CAR T cell therapy. So without taking much of time, over to you, Dr. Abhishek. And I would like to share with all of you proudly that at our center, uh, Dr. Abhishek Charan has done a lot of autologous transplant and he has completed three patients of the CAR T cell therapy also. And all credit I should give to him that to initiate to take care of the CAR T cell therapy in the perfect manner, whatever the resource constraints we have at the end of the patients. So over to you, Dr. Abhishek Charan.
The use of dual CAR T in lymphoma patient, those who are refractory to it. Coming to the background of CAR T in DLBCL, as we all know, the first trial of CAR T was Zuma 1 trial, which came in 2017, where the refractory and relapse cases were without any option were addressed to give CAR T. And that time, CD19 CAR T was the first CAR T which was manufactured and it was tried. Most of the patients at that time were refractory in these cases, and it gave a hope that these patients who are refractory and those who have relapsed, there can be a one option which can cure and give a long remission. So it was assessed and it showed that over a period of time, in 2023 the 5-year result came for Zuma 1 trial, which showed around 30 to 40% had 5-year OS at the end of 5 year, and which was quite significant. But it also highlighted a one problem, that almost 60% of the patient were not able to achieve a long-term remission despite having a CD19 marker upfront. It was present in the those refractory or relapsed lymphoma. So when assessing what was the failure, what was the reason of the failure of these patients, two or three factor which came out. One was the disease burden, second was the biology, and third was the loss of your CD19 marker. So over a period of time, once you have infused the CAR, what will happen, that resistance will develop in your tumor cell and they will lose the CD19 marker. And most of the relapse, when they were assessed, it was seen that they had CD22 as compared to CD19 was lost. So then the next question came, so can we incorporate CD22 upfront, or can we give it post, or like tandem post CD19 or CD22? So this was tried in many West countries also, and in Asia also, in China and Japan, it was Korea, it was studied, and they found out that either you can go for CD19 followed by CD22 tandem, or the latest was in 24 and 25, where it can be combined and it can be used as a single and entity, and it can be incorporated. So I'll be talking about a single dual car which will involve CD19 and CD22. So as we all know, CAR is a chimeric antigen receptor. So the basic funda in this was that your single chain variable fragment, that is your external factor which will bind to your antigen receptor on tumor cell with CD19 and 22, will have a fragment was derived from both CD22 and CD19, and it was clubbed together and made as one single factor which will go and bind both with CD19 and 22. So the science behind this is, earlier only CD19 was used because CD19 was available in more cluster. The amount of CD19 receptor in on antigen tumor cells were more, and the response, the I mean triggering of a response and the binding affinity was more with CD19 tumor cell as compared to CD22. But the over a period of time there was loss of CD19. So when, and after that, once the patient is about to relapse or has relapsed, the CD22 marker has come as the upfront and the most common and most widely marker in such patient. So CD22 marker, if it binds upfront also along with CD19, the binding will be slow because the your CD22 is in less quantity as compared to CD19. CD19 will be in so much amount, so there will be saturation of that, and it will almost give a instant response. But CD22 will be in less, and it will get saturated over a period of time. So this is what the both things has been combined, and it can overcome the resistance. So this trial, as many other trials which has come, I mean, there is one more trial of dual CAR in ALL patient. So this trial focuses mainly on large B cell lymphoma. As we all know, the timeline of CAR products, once we do apheresis, then we give the bridging therapy, and then we give CAR conditioning, which is the same in this trial also. They also use FC regimen, and it was given in this the standard CAR dose was 2 million was given of CD19 CD22 clustered CAR, and the primary endpoint was overall response rate, as it was seen in Zuma 1 and Zuma 2 other trials. And secondary endpoint was your CRR, complete response rate, PFS, OS, and your adverse event. Next, please. So bridging regimen is up to the physician. Even in this trial, it was, I mean, physician choice. But most of the patient received MPT regimen. The reason behind using MPT regimen was patient were already exposed to 2 to 3 lines, and they were not exposed to mitoxantrone or polatuzumab. So it was a preferable bridging therapy, and there was the only reason being not exposed and not utilized upfront. Next, please. So patient characteristic were more or less it was a refractory patients, relapsed patient with advanced disease. Most of the patients were from stage 4, and the refractory patient constituted almost 74% of the cases. IPI score was also high, more than 2 in almost 70% of the patient. So it shows that your patient profile, biology and everything was disease load was high, refractory cases and with high IPI score. So it forms a more challenging part. Next, please. So the as I already mentioned, the most of the patient were exposed to almost 3 to 5 lines. So more than 2 lines were involved in given already in 55% of the patient, and the efficacy of bridging therapy was also assessed. So once you have given the MPD, and just before your CAR infusion, PET was done, which showed that all almost all patients were in SD, I mean stable disease. So the use of MPT regimen, because they were heavily treated, so MPT regimen did not lead to any, I mean, substantial decrease in your disease load. It just maintained a stable disease. It avoided the progressive disease. So MPT regimen, in a way, is not that, I mean, fruitful in this case, but it did prevented your progressive disease because patients were already exposed to 3 to 5 lines. And prognostic wise, yeah, previous once right, back please. And prognostic factors, those who had double expressor or double hit were more involved, and P53. So the prognosis or the, I mean, relapse or refractory cases in DLBCL, the most common factor is your, I mean, genetic expression, double expressor, double hit, or also like P53, MYD88, and your other factors like MYC. They all constitute the prognostic poor factor, and in this trial also it involved all these factors. Next, please. So overall efficacy at 4 weeks was assessed from this, and overall response rate at end of 1 month was 93% patient had response, out of which almost 60% had complete response rate. So this was substantial, keeping in mind the disease load and the poor biology and the aggressive nature of the disease in these selective patients. And with a median follow-up almost 4.2 months, the CAR infusion patient had overall response rate was still 100% at the end of 4.2, and comprising almost two-third patient has complete response rate and one-third had partial response. Next, please. So this is a plot, forest plot, showing the subgroup analysis where it shows that p-value was significant in the male patient. So it showed a good result in male patient, though the trial involved most of the female patient, almost two-third, or and bulky disease showed a good result. So as compared to isolated CD19, where we see that if you have low disease burden, then you have a good result. But in this trial, because of the dual nature of your CD19 and 22, even the bulky disease patient had responded well. And the most important part is your prognostic marker, double expressor or double hit, showed a good result. So this is important. Next, please. So with a median follow-up almost 4.2 months in CAR-T, the median PFS and OS was not reached, and the 6-month PFS and OS was almost 83% and 87%. So it is quite significant. At the end of, because this trial is still going on, and the abstract, only the abstract has come. The full paper is yet to come in next year, maybe most likely after completion of 12 months. So at the time of data cutoff, 93% of the patient treated were remained alive. That's important. Only 2 patients expired, and out of which one death was non lymphoma related. So in a way, only one patient has expired due to progressive disease. So it is quite promising and it is quite good. Next. So 90% of the patient exhibit peak CAR-T expansion during 10 to 14 days, with a median peak CAR-T around count of almost 2 billion cells, 2 million cells. And this was also detected, and this was followed even at 3 months. The persistence of CAR was maintained. The reason for persistence of CAR, because they also utilized post CAR, they gave PD1 immune checkpoint, PD1 immune checkpoint inhibitor, nivolumab was also used, so that maintained your persistence, I mean that helped in maintaining your car, and the persistence of car was seen in this. Next. So as we all know, the I mean CRS icons are most commonly seen in first week of your infusion, and the same was seen in this trial also. The peak IL-6 concentration was between 4 to 7 days, and most of the patient did require tocilizumab because of the dual nature of your car, and this was most of the patients were manageable, and there was no as such TRM related to these dual car. Next, please. So this was one of the interesting finding where it showed that at the day 30, the first assessment after in one of the patient had a progressive disease post CAR, and patient was already exposed to PD-1 inhibitor, but still they went on and gave PD-1 again, and subsequently they observed that post giving PD-1 the patient went into CR, and the logic behind is that because of CD22 delayed activation and delayed proliferation of CAR because of CD22. CD19 will cause your CAR activation and proliferation in first 2 weeks. CD22 may cause it delayed also, even in second to third week also, or even in fourth week also in some of the studies. So because of the delayed CD2 activation and all that, and PD-1 inhibitor, I mean immune checkpoint inhibitor, helping to proliferate and propagate this CAR. So this shows that CD22 activity along with PD-1 can sometime cause a good, give you good result. And even though it, and in this patient, it did had a progression at day 30, but at day 60, the patient had CMR. So because of delayed activation of CD22 and your immune checkpoint inhibitor shows, it shows the maintenance is very important, and choosing a right maintenance drug is very important. Next, please. So the side effect profile was almost same, more or less same. Grade 3 and 4 side effects were almost 20%, and most of the patient had CRS, which was managed symptomatically or tocili was given. Myelosuppression was common, and it's seen almost 90% patient involving having neutropenia, thrombocytopenia, and anemia. So side effects were more or less same as compared to CD19 isolated CAR, auto CAR, or even in the dual CAR. The side effect was not a concern. Next, please. So coming to the conclusion that this dual CAR is already being explored in your ALL along with that DLBCL, it is showing quite promising result. Side effect is quite manageable, and it's not has increased because of the involving your CD22. It did show that response can be better as compared to isolated CD19. The most of the facilities are all, I mean, they are trying to incorporate CD22 upfront also, and by 27 or 28 we may also have CD19 and 22 dual combination in India if the trial in India is I mean what I hear from others that they are planning to start a trial in 26 mid. So let's see. Thank you so much.
Thanks, Dr. Abhishek, for giving the insight about the newer upcoming potentially game changer in this particular field. Dr. Prakash, you want to make any comment? What's your view that how is going to make the difference versus the CD19 or the single target based the CAR T cell therapy?
Yes, sir. It was a good presentation, very beautifully explained. As Abhishek rightly pointed out, if we are using two different antigens, especially the 22, which is ubiquitously present, and it's not as easy as 19 to down-regulate the 22. So it is often the cells will not evade your CAR T against only CD19 when the down expression is more common. You lose response after 4 or 5 months. But CD22 down expression is not so common, so the chances of persistence is more, and we anticipate a very good result with CD22 and 19 dual CAR.
Any other comment from any participants? So once again, thanks, Dr. Abhishek. And now over to Dr. Prakash Singh Shekhawat, who is consultant hematologist at Bhagwan Mahavir Cancer Hospital. And I must say that he's pioneer in the autologous allogenic transplant as well as in the CAR T cell therapy. And recently has been updated that they have started the DRNB course in the hematology also separately apart from the medical oncology courses. So congratulations to you, Dr. Prakash. And he will be rightly talking about from the infinite to the finite treatment in the CLL. We have witnessed that the treatment of CLL used to be the continuous treatment. You go on giving it till the patient progresses or intolerance is there. But now we today talk about that how we can make the treatment fixed duration, which is other than the cytotoxic drugs. And we may think of the sort of the functional cure what we achieve in the case of the CML may not be equal at this stage, but yes, that time is not far away. So over to you, Dr. Prakash.
Thank you, sir. Thank you for your kind words. And can I present?
Yes, please go ahead.
Yes, yes, sir.
Sure, sir.
So you, okay. Is it visible? So we will be talking about venetoclax. It's a BCL2 inhibitor, and the title has been rightly chosen as shifting gears from infinite to finite. So as we all know, most of our CLL patients, are the slides moving? So it's a these are the disclaimer from AbbVie. It's a sponsor talk, and I will be talking about venetoclax. So what are the different drugs which we currently use for our CLL patients? One is a BTK inhibitor. We are having covalent BTK inhibitors like ibru and acalabrutinib. What they do, they bind to the B cell receptors. These are Bruton kinase inhibitors, and the drug is intaken by endocytosis, and ultimately it causes cell death. The second is venetoclax. Venetoclax is a protein which helps in cell apoptosis. So it's how does it do? Because BCL2 are proteins which are anti-apoptotic. And if we are inhibiting BCL2, then we are causing the anti-apoptotic nature to change to pro-apoptotic nature. Ultimately, with the help of cytochrome C, then caspase 8, caspase 9, and activation of caspases will cause cell death. We also have the CD22 receptor antibodies like rituximab is there, ofatumumab was there, obinutuzumab is there. So currently rituximab and obinutuzumab are available and are used, approved for CLL. So two small molecules, one is BTK, one is BCL2 inhibitor, and another one is a surface antibody like CD20 antibody. So these are the drugs which are available, and we are doing permutation combination with these drugs. So initially the CLL, initially with any other cancer, like as the drug discovery and science has evolved over past half century, the CLL treatment has evolved a lot, because when we started, I was a new one to start, and we have seen the rituximab era at its peak. Initially, in 60s and 70s, it was just to alleviate the symptom, to decrease the symptom burden. Then there was improving the quality. Then came the long-term PFS and the disease control. Now the MRD approach is there. Now we are again talking like CML, where we are going for TFR. CLL is also moving like CML way, whether we can do something which will give us a good result in a finite time. So no need to give indefinite therapy or repeat therapies over and over again and maintenance. So they are trying to use something which can have a 9 month, 1 year, 2 year kind of treatment. So this all has been changed after introduction of venetoclax. So venetoclax in early part of 2010-12, venetoclax was there, and after that venetoclax has been tried in CLL14, then it has been tried in Murano, and we are seeing venetoclax as a pillar for a finite therapy. So the NCCN, the latest NCCN also recommends in its first line therapy, specifically the preferred regimens are small molecules, venetoclax, or it can be combined with obinutuzumab or venetoclax with acalabrutinib plus obinutuzumab in amplified trial, or you can do with single agent janubrutinib, already available in India, but it's a costly drug. We can combine Ibru plus Ven also, or in Ibru single category is also there, acalabrutinib is also there. So single agent covalent BTK inhibitor plus it's CD20 or a BCL2 inhibitor. These are the preferred regimen. Then in some cases where the finances are a challenge, or if it's a IGHV mutated with young fit patient, we still have some role for chemotherapy like FCR. But mostly we are moving away from chemotherapy. We are using an anti-CD20 monoclonal antibody along with one of these two molecules, either BTK or a BCL2 inhibitor. We almost certainly have moved away from chlorambucil, prednisolone, and FCR kind of therapy. So the ESMO, recent ESMO, we are talking about the updates. The recent ESMO clearly says if your patient is in early stage, symptomatic, or if it's an advanced stage, then only we are going to treat, because asymptomatic CLL can be kept on wait and watch for decades. So for these cases, initially our approach was to see whether he or she is IGHV mutated or not. Nowadays, even if it is IGHV mutated, we see if the patient is young, fit, this venetoclax is approved frontline along with obinutuzumab, or ibruven is there in a little small bracket of IGHV mutated with a fit nature, we can still go for FCR. If the patient is 17p mutated, then a BTK inhibitor and BCL2 inhibitor combination is best. We also have an option of idelalisib with rituximab in this bracket. If it's unmutated, both TP53 and IGHV both unmutated. Nowadays, the mutation profile is not going to change your treatment approach, because in all the categories, BCL2 inhibitors and BTK inhibitors are approved as frontline. So even if it is IGHV mutated, unmutated, TP53, deletion 13q, trisomy 12, everywhere you can use these drugs. They have been approved first line. So the zoomed version, if it's a CLL who has relapsed, then we again see the same approach, whether the patient is symptomatic or not, and does he or she needs a treatment. So it all depends whether the treatment was in previous 3 years or more than 3 years. If the subject has already passed more than 3 years of previous therapy, then we can resume the same therapy. If he is progressing on a BTK inhibitor, then change to non-BTK kind of drug, or if there is a new acquisition of TP5317P, then we are going to add BTK inhibitors along with venetoclax. So after a previous chemoimmunotherapy, the first relapse, now we are not using chemoimmunotherapy, even if the subject is a late relapse. And the current options which are available in India, as I discussed in my previous the slide, we have chemotherapies of which there is fludarabine or cladribine, then alkylating agents like cyclobendamustine, still commonly used in tier 2 cities, and sometimes when their resources are not there, there are immunotherapies of which rituximab is the main pillar, Obinutuzumab is very good. A single drop can cause a lot of havoc of obinutuzumab, but being a costly drug, we are not using it as frequently as rituximab in our CLL patients. Then targeted therapies like PI3K inhibitor, BCL2 inhibitor, venetoclax, navitoclax is also coming. Then we are using acalabrutinib, which is within reach, and generics are available. So the combination is a permutation combination. Any two of these three classes are easily combined with each another, but the most potent is venetoclax plus acalabrutinib plus obinutuzumab, or ibrutinib plus venetoclax. So frontline, when a patient of CLL comes to us after deciding whether they needs therapy, then we are discussing whether the subject wants a continuous therapy or a fixed duration therapy. The continuous therapy is ideally lifelong. There are drugs which can cause some serious side effects, especially because CLL is a disease of elderly. So in the late 60s, late 70s, when CLL comes, the patient already had some comorbidity, especially in terms of uh, metabolic disease, especially in terms of cardiovascular disorders. So there are certain drugs which need to be carefully played with. And if you are choosing a fixed duration therapy, then you can still take that risk because you are going to omit those drugs, say, after 1 year. So mostly the patient are nowadays opting for fixed duration therapy, because if you counsel them nicely, they do agree. And here we have this venetoclax, obinutuzumab, or Ibru plus venetoclax. And the another one which was seen in ESMO and NCCN is venetoclax plus acalabrutinib, which is easy because acalabrutinib, being the second generation, has less side effect on hurt and bleedings in comparison to ibrutinib. Chemoimmunotherapy still has some role, but nowadays very little discussed about this. So we explained the continuous therapy, we have explained the fixed duration therapy. How do we choose? First, it's a shared decision where you need to discuss everything along with your patient. You give them the options, let them decide. So, but this is, I think, the Western era. In our country, whatever I explain to the patient, ultimately he says, "Sir, आपको जो ठीक लगता है आप वो बताइए." So, in spite of 15 minutes of counseling, they will ultimately come back to your, that is, you take which to choose. But we are doing, we see the age and frailty. Most patients are elderly, they have some kidney and some cardiovascular issues. Then we need to see for their infection risk also, because especially the BTK inhibitors or a long-term CD20, it can cause a significant viral reactivations and risk of infection in terms of both immunosuppressed baseline and the drug causing immunosuppression further. Then we are seeing the biology, especially if there is TP53 status is there or not. IGHV is not going to do much of change if we are using small molecules. And then we see the cost and the side effects and interaction with other drugs, ease of administration. All these things needs to be taken into account and choose what fits best. So we can see if we are using continuous BTK inhibitors along with a CD20 antibody in frontline newly diagnosed CLL, the PFS we can see with ibrurituximab in the first bracket. We are seeing compared to FCR, it is significantly better. And if we are using the Elevate TN and trial, Elevate trial both for the refractory cases and Elevate TN for treatment naive cases, where we have seen that if we are using acalabrutinib with or without obinutuzumab, the chances are much better when compared with the third arm of chlorambucil and obinutuzumab. So acala alone is better than obinutuzumab chlorambucil, and if it is combined with obinutuzumab, it is even better. So this is showing that if we are using a BTK inhibitor, then our chances, Secure trial has also shown that if you are using genobrutinib continuous, then your chances of PFS is much better and it's statistically significant. In the Elevate TN trial at the time when it was published in 2023, the median PFS was not even reached. So these drugs are doing some wonder. And we can see the PFS and time to next treatment in CLL14 when venetoclax was combined with obinutuzumab versus of standard of care with chlorambucil obinutuzumab. And that the 6-year PFS with ven-ob arm was 53%, whereas it was in 21%. So more than double PFS with ven-ob in CLL14. And even the time to next treatment was significantly better. So in 6-year period, 65% were free from next treatment versus 37% in chlorambucil obinutuzumab. So we see that if we are using venetoclax also with obinutuzumab, then your PFS is way better, and it's your time to next treatment is also prolonged in case of when obinutuzumab arm. So obinutuzumab is a drug which is anti-CD20. We are now very much comfortable with rituximab. The only problem is infusional toxicity, and obinutuzumab is much worse in terms of infusional toxicities. So if you're using obinutuzumab in your first cycle, you need to be very uh, much proactive. You need to be on your toes in terms of infusional toxicities. A little bit of drug, it causes significant TLS, it can cause significant infusional toxicities. Very potent drug, but the infusional reaction is uh, severe, and almost 20% patients needs the drug holding because of infusional toxicity. Otherwise, it's a beautiful drug. We can see 20% risk of this toxicity. And if we are using venetoclax, because it is a pro-apoptotic drug, so it will cause TLS. So in like most hematotoxic malignancies where the risk of TLS is high, CLL per se, like CML, doesn't have much of hematological TLS kind of risk. But with these potent drugs, especially if the WBC is more than 25,000, then both your rituximab and obinutuzumab can cause significant TLS. And if you are using a lytic drug with a venetoclax, because BTK doesn't kill your cells so easily and so fast, so the risk of TLS is not prominent with BTK inhibitors. But if we are using BCL2 inhibitors, it's a pro-apoptotic drug, it can cause significant TLS. So when your TLS risk is high, you need ramp up dosing from 20, then 20, then 50, then 100. Subsequently, over a period of 1 month, we gradually increase the dose to its full dose of 400 mg. Although in India, we are not using complete dose, we are playing with azoles and decreasing the dose, but we need to have a aggressive hyperhydration. We need to use anti-hyperuricemic drugs. Sometime a raspberry case is also warranted in case of venetoclax-based therapy. And there are different factors which needs to taken into account in terms of infection risk. So CLL, as we all know, it's a disease of mature B cells. So there is an abnormal level of gamma globulins. So you have an increased risk of infection. Then because of your chemotherapeutic drugs, you have increased risk of infection. Then because of your age at which the disease comes and multiple other comorbidities. So most patients of CLL should be advocated for vaccines, which is very important. Whatever response it gives, give a vaccine. At least the influenza and the Shingrix and pneumococcal, these are important vaccines. They do protect the patient from morbid pneumonia, at least. So the vaccination is important. Then if we know which patient is at high risk of infection, then we can do baseline IgG monitoring also. If you have immune paresis or if your IgG is very significantly low, then we need to top up with IVIG at least monthly, 0.4 mg per kg, which alleviates a little bit of your infection risk. Vaccines are also there. Then we need to use mm, antibiotics and antivirals also. So BTK inhibitors, infection risk of HAV, then hepatitis B and pneumocystis. BCL2 doesn't cause this much of infection. Rituximab again and obinutuzumab, they also causes the viral reactivation. So we need to check for hepatitis B core antibody total also. If the patient has been previously exposed, we are giving entecavir. If the subject is on rituximab, there is a certain risk. We need to use a cyclovir also, Septran, which we are commonly doing vaccinations and these drugs, they somehow mitigate the risk a bit. So if someone is having this risk, we need to see that a subject of CLL and multiple myeloma, where B cell and plasma cells are affected and they have less IgG against infection, so they are at least 700 times more prone for major pneumonia compared to their counterpart. And if they land in ICU, the cost can go to 4 lakh, 5 lakh for a 10 days admission with a risk of mortality. So IVIG is at times needed. TP53 mutation we talk everywhere in our malignancy, each and every disease. It's a guardian of genome, we know. So mostly what happens when the TP53 is mutated and deleted, if the both are gone, then the chances of the subject responding to treatment is not good. Chemo radio are unlikely to work. Then we need these small molecules, targeted molecules, which somehow can root and bypass the cell killing by TP53. Still, it is not a good disease. We can see that obinutuzumab and venetoclax, when combined together in TP53 deleted mutated patient, the median PFS was 51 month compared to no TP53 76 month. Means even these drugs are not doing as good as they should do.
Sir, sorry for interrupt you. Please kindly
Only
complete.
two, only two, three slides more. So we can see if we are using continuous BTK inhibitors along with CD20 in our previous slides also, the PFS is better. And if we are using in the CLL14 trial, VEN-OB versus chlorambucil obinutuzumab, we can see it is favoring this in all, whether the status is mutated or not, whether there is bulky disease or not. And venetoclax has also been tried in Murano trials for relapse refractory CLL. In, in relapse refractory cases also, venetoclax is doing some good work. In all these Ascend and Resonate and Elevate RR and Murano, we can see that this drug is working well. It is a relatively safe drug. Apart from the TLS, the risks are very low. What are its main practicalities? We already discussed. We start with very low dose, 20 to 50 per day, and subsequently by the end of 1 month, we ramp up to its maximum possible dose, although we are not going to 400 mg per day. And we can see if the disease bulk is very high, bulky disease more than 5 centimeter lymph node or more than 25,000 TLC, risk of TLS both with rituximab and also with venetoclax. So it's a first-in-class BCL2 inhibitor which has been approved. It has also been approved along with acalabrutinib as per the Amplify trial in NCCN, and we are seeing good result with this. If you are combining venetoclax with a CD20 or a BTK inhibitor, we can limit therapy from unlimited to a period of 1 year, just to see whether the TLS risk is there or not, and we need to gradually ramp up the dose to look for diarrhea. Thank you.
Thank you, Dr. Prakash. I think there is a comment and question in the chat box for you by Dr. Vinod Sharma, medical oncologist.
Given the indefinite timeline with BTK inhibitors, when can one stop acalabrutinib in CLL P53 wild type provided that the disease is in remission? Sir, we need to see if we are using only one drug, that is only BTK inhibitors. Guideline doesn't say to stop. But if the subject is in remission and we have used almost 2 years of BTK inhibitor, there are data which now they are they are keeping these patients off therapy, but still not has been recommended. You can use 2 years of BTK, then you can stop. Single agent.
Thank you, Dr. Prakash. If no more comment, then we move to the next session. And the next session is by Professor Hemant Malhotra, sir, Professor and Head Director Oncology Services at Mahatma Gandhi Hospital. And I must congratulate him once again for successfully conducting the recent ISMPO National Conference. And who can be a better person or a legendary person in field of the CML in country to take this topic. And once we have more and more these drugs, first generation, second generation, and now the drug third generation, or with a different mechanism of action. So it becomes more difficult that which are the patient for the which drug and how to choose wisely, keeping the long-term use of these drugs, how to achieve the TFR and so many other factors. To have this with the panel, hand over to Dr. Malhotra sir and to invite his panelist also. Over to you, sir.
So can you hear me and see me, Naresh? Am I
Yes, sir.
audible and
Yes, sir.
visible?
Yes, sir.
So good evening, everybody, and many thanks to Naresh for this opportunity. May I share my slides? Is it possible for me to do that? Can I attempt to share my slides?
Yes, sir.
Uh, are my slides visible?
Yes, sir. Make it full screen, please.
I have made it full screen. Can you see?
Yes, sir.
Okay, wonderful. So, thank you for this opportunity. My pleasure and privilege to do this session on CML. Particularly impressed with Dr. Prakash's talk. Very nice talk, Prakash. My congratulations to you. And we'll move on with the program. Like to invite on board my panel, Dr. Vishnu Sharma. He is the head of hematology at SMS. Very happy that Vishnu has his own department now. Dr. Vinod Sharma. I can see Vinod there. Vishnu, are you there?
Yes, sir. I've joined.
Wonderful. Apna camera on karo yaar.
Yes.
Yeah, we want to see your lovely face. Dr. Manoj Mahajan is like one of the leading oncologists in our state, and he operates from Udaipur. Manoj, are you there?
Yes, sir.
Wonderful. Put your camera on. Great.
Yes.
So, like three very, very learned panelists, and we are going to talk about a common disease. We're going to talk about CML CP and what is the best first line treatment. It has been discussed many, many times, but we'll see if we can thrash out and include the new drugs which are available now, albeit very expensive. So, what is the exact place of these drugs in the newly diagnosed patient, and what do our panelists and our leading practitioners, what are known as key opinion leaders of the state in the field, what advice they have for you? So I'll present a case to my three panelists and ask them questions. And this is a little bit of information for the young audience. I hope there are some residents also watching this. So you must remember that there have been several publications now that indicate to us that if a patient of chronic phase chronic myeloid leukemia is well treated, then the life expectancy of that patient is the same as for general population. And this holds true for males as well as females. And this holds true for younger patients as well as older patients. The dotted bar is life expectancy of the general population, and the broad bar, the yellow curve, is of patients with CML. And then you can see that in the past decade, 2010 onwards, since the availability of effective treatment, the life expectancy is close to that of normal. But there is one caveat to this: the patient has to be properly treated, the patient has to be properly monitored. So let's come to our case now. So we have a 34-year-old male who works in a bank, who is a manager level in a bank. He presented with the usual signs symptoms of CML, malaise, weakness, anorexia, lump in the left abdomen, a very large 20 centimeter splenomegaly, total counts of 320,000. Some blasts in the peripheral blood, some basophils, some eosinophils. Marrow was hypercellular with shift to the left with 4% blasts. Karyotyping shows Philadelphia chromosome. BCR-ABL is positive, and on the international scale is 68.9%. So we have a final diagnosis of a myeloproliferative neoplasm, chronic myeloid leukemia chronic phase, high SOCAL risk, high UTOS score, high Hasford score, intermediate ELTS. So one more input for the younger people in the audience. When you are seeing a patient of CML in your prescription, in your case sheet, please make sure that you write all the parameters for which you can determine the SOCAL, the UTOS, and the ELTS. Even if you don't determine the score, it will be good if you determine the score or have those parameters mentioned at diagnosis so that later on when you're analyzing your data, you can calculate the scores. So now in addition to hydration, allopurinol, hydroxyurea to get the counts down, what specific treatment would my panelists want to do? And I want each one of my panelists to comment on this. I'll start with Dr. Vishnu. So Vishnu, this patient comes to you. What would be your choice of treatment as first line for this patient? I intentionally specified that this patient is a banker, so reimbursement is less of an issue for this patient.
So, sir, looking at the disease characteristics and the current data available with us for various treatment options. So, my first option would be asciminib 80 milligram OD or 40 milligram BD if there is no like financial limitation is not there. If financial limitation is there, then definitely dasatinib 100 milligram once in a day.
Okay, so Dr. Vishnu is absolutely categoric in his choice that he would use asciminib as first line in a patient who doesn't have any economic restrictions. So let me ask Dr. Vinod now. Same question to you, Vinod. What would you do in this patient? And please remember that this is an independent session. Novartis has nothing to do with this session.
Yes. So,
Yes.
sir, my answer will depend whether the patient need TFR. There is a goal if TFR or not. So, if TFR is the goal, then the first choice can be dasatinib or asciminib. Both are reasonable to me, and down the line imatinib. If TFR is not an option, then imatinib will be one of the part, including dasatinib and asciminib. Nilotinib because of cardiac issue, I would not prefer, and bosutinib because of GI toxicity. And if I am planning for asciminib, I will probably counsel for NGS to rule out baseline AXLN mutation that can be present in 10% of cases.
Okay, I have a question on that, so maybe we can discuss that more in detail. So let me go get to Manoj. Manoj, what would be your choice, please?
So patient has high Sokal index or UTOS score, so definitely high risk patient. So first line, like first option would be asciminib if there are no financial constraints, or in any other situations we'd prefer dasatinib 100 milligram OD.
Okay, so I can see Naresh also there. Naresh, you are one of the leading practitioners in Jaipur and in Rajasthan and in India. Maybe I will also include you in these questions. What would be your choice of treatment in this patient?
So
See,
my
yeah.
practical choice, as being told by Dr. Mahajan, is that most of the patient they land with the dasatinib. Sometimes we give them only 50 milligram to begin with, and then try to make it 100 milligram. And if the patient is intolerant to 100 milligram, then even I'm comfortable with the 50 milligram. With the newer data of the asciminib, yes, if I have to achieve more and more TFR or the deeper and durable response, and the possible difference in the outcome, then maybe that I will do the counseling for the asciminib also. Usually, I resist to prescribe the nilotinib upfront, looking at its various toxicities and more intensive monitoring, and especially the cardiac potentiality of the toxicity in the long-term patient. And most of the time, I don't prescribe imatinib 600 milligram because of the intolerance to the patients.
So I think we have a good response from all our learned panelists, and again for our younger audience, all the guidelines, NCCN, ESMO, ELN guidelines published earlier this year, all of them recommend that for a high risk patient, high risk means high focal risk or high ELTS score, it is good to start with a second generation TKI. So the recommendation of first choice is a second generation TKI. And we in India are lucky that we have generics for all the second generation TKIs, and they are not as expensive as they are in our Western countries. And also with the two first-line trials which have now been published, there is a recommendation by all guidelines that you can also consider asciminib as the starting treatment. But asciminib remains very costly and it remains out of reach of a majority of patients. So one more question to our panel, and I think Dr. Vinod did refer to this. Let me ask Manoj. Manoj, would you ask for a BCR-ABL kinase domain mutation at diagnosis for all your CML patients?
Usually we don't go for it, but as patient's financial banker, so I would like to go for it because considering all medical legal issues and all recommendations, I would go for it. But 99% times we don't go for upfront mutation testing.
What is your opinion, Vishnu?
Sir, I think it is not advisable at baseline. And TFR should be goal for everyone, sir, irrespective of, I think, especially for young patients like this patient. So we should choose best treatment options like second generation TK or asciminib, irrespective of so-called score, sir, or in my opinion.
So now we are talking about kinase domain mutations at diagnosis, and I completely agree with Dr. Vishnu that as of today, it is not recommended in the guidelines. None of the guidelines say that at diagnosis, a newly diagnosed CML-CP patient should have a kinase domain mutation testing done. However, there are studies and there are some publications that about 10 to 15% of patients may have mutations at diagnosis, and 10% of patients may have ASXL mutations. And then again, you don't know what to do with these patients. So as of just now, you are not mandated to ask for a kinase domain mutation testing. And Manoj, you're legally absolutely safe if you don't ask for a KD mutation at diagnosis. If there is suboptimal response or there is progression, then of course you have to ask for it, but not at diagnosis. So I think from this panel, we have to send a clear-cut, unambiguous message that kinase domain mutations as of today, maybe next year or the year after that, this might change with the accumulation of more data. But as of just now, it is not recommended at diagnosis. So now again, this is a question for my panel, and I want each one of my panel to address this quickly. What would be your goal for this 38, 40-year-old patient? Start with Dr. Vinod. Vinod, can you tell us, and don't tell me that all of them would be your goals, what would be your number one goal for this particular patient which we are discussing?
So, sir, this patient was actually intermediate risk ELTS. So for high and intermediate, my first goal will be first to prevent progression to AP and BC that can happen in about 5 to 6% over a long.
Okay, and so I move to Dr. Manoj. Manoj, what would be your goal out of these five which I have listed here? Or if you have a sixth goal, you're happy to highlight that also.
Sir, young patient, I think target would be probable treatment-free remission and aim at cure.
Okay, good. Vishnu?
Sir, first goal is to achieve and maintain deepest possible response with good quality of life.
Okay, and Naresh?
I am very clear. Point number 3, treatment-free remission is my always goal in younger patients.
So there you go. Like we have four panelists. I don't know. We have three panelists and one super panelist,
No,
and
sir.
we have five goals over here, and we have one of our experts choosing one of these goals. So just to convey to you that all these five goals are important when you have a patient of CML-CP. So if you can choose any one of these are absolutely fine.
Sir, my goal is actually overlapping with Naresh's goal. Deepest,
So
to achieve deepest
included,
possible response so that we can.
you've included two goals into one.
Yes, sir.
So we are all aware of the head-to-head comparison between imatinib and
Sir,
dasatinib.
can I make a comment here?
Yes, please.
When we treat the breast cancer and few other malignancies where we the cytotoxic drug as the curative treatment, like typical like breast cancer, and our intent remains the cure of the patient, and we always try to tell the patient aggressive chemotherapy, extended chemotherapy, extra drugs like PARP inhibitor, like CDK4 inhibitor, like change of the anti-HR drugs with the no touching PCR. Ultimate goal remains the achieving the CR. Ultimate goal remains the cure and the prolongation of the survival. So the in a younger and fitter patient, quality of life, avoiding the complication, in my mind, goes as the second priority. The cure and the treatment-free remission and the functional cure remains as the priority.
Okay, point taken. Because I have a few more slides to do and something more important to discuss, I will accept that and not argue on that. So, like this is the head-to-head comparison between imatinib and dasatinib, and we can see the nice big difference in terms of MMR, in terms of MR4 between dasatinib, between the second generation TKI and imatinib, and similar results with the nilotinib as compared to imatinib, like a big widening of the curves with related to MR 4.5. And here are all the, this is the bosutinib, the before trial and the Bela trial. Again, a difference in all parameters as compared to the first generation TKI. And that is why there is an unambiguous recommendation in the guidelines and an unambiguous recommendation by our expert panel that if you have a high risk patient, then it is advisable to start with the second generation TKI and not a first generation TKI. Now, here is the new kid on the block. We have this data of first line asciminib, the AC4 first trial, NEJM publication, ASH presentation. And here, a very big difference between asciminib and imatinib, but not such a big difference between asciminib and the second generation TKIs. So just look at this. The difference is it's just a shade better, not massively different. So that you need to keep in mind, and it is very early days with asciminib. And here is the toxicity. So one of the major aspects of the first line and the second line asciminib trials is that it is very, very well tolerated. As compared to imatinib, it is much less toxic. As compared to the second generation TKIs, it is significantly less toxic. The AEs leading to discontinuation are the fewest with asciminib, and leading to dose interruptions and adjustments are again the fewest with asciminib. So that has to be kept in mind. Also keep in mind that even though we have a significant gain in terms of cytogenetic response, major molecular response, deep molecular responses, the difference in overall survival with second generation TKIs as compared to imatinib has still not shown up even after 10, 15 years. So the same might be true for asciminib also. And then toxicity is a very, very important. You have a patient, even if the patient is eligible and qualifies for a TFR, the patient is looking at a minimum of 3 years, 4 years, 5 years, 8 years of exposure to the TKI. So you have to be very familiar with the side effects, the short-term toxicities, the hematological toxicities, the non-hematological toxicities of each of these agents which you use. And if you are familiar with these toxicities, anticipate them, look for them, then you will be doing a big service to your patient in terms of maintaining his or her quality of life. So back to our case, the patient was started on dasatinib, 100 milligrams. Sorry, they should read OD. The patient did not have a optimal response. Even at 6 months, the patient's BCR was 12.6, where it should have been way less than 10, preferably less than 1. An imatinib resistance mutational analysis by NGS was ordered, and this threw up the 315I mutation. Now back to my panel, starting with Dr. Vishnu. What would you do now, Vishnu?
Sir, because asciminib is available now in India, and if patient is affordable, then definitely asciminib 200 milligram be.
So can you tell me the monthly cost of 200 milligrams asciminib, and for how
It
long
is
it has to be given, and the yearly cost?
it is around 9 lakh rupees per month, and if you adjust the PEP, it becomes 4 lakh 5. 4.5 lakh per month. So it becomes like more than 55 lakh with PEP.
55 lakhs, half a crore of rupees every year, and
Yearly,
then
sir.
it has to be given for several years if a transplant is not planned or if the patient is not a candidate for transplant, right? So can
Yes.
our country, can SMS, can government of Rajasthan, government of India afford that kind of treatment?
So
It's it's an unfair question, but
we are
do we need to think of that?
we are providing to few patients T315I, 200 milligram BD through RGHS
So where is the money coming from, Vishnu?
from our pockets.
So it is coming from the taxpayers' profit. So, just a submission to my learned panelists and to my listeners that even though the patient is getting the medicine from somewhere, if it is really indicated, we have to use it, no question about that. But if it is borderline indicated, then we also need to think of that. If we consume the Rajasthan government budget for 50% of the budget for asciminib, then how are we going to treat our non-Hodgkin's lymphomas? How are we going to treat our germ cell tumors? So that has to be kept in mind, and that depends on your thinking. Manoj, do you agree or do you not agree?
Sir, if patient is paying from pocket, then it's okay. Rest, I agree with you.
And what about you, Dr. Vinod?
Same, sir. Very true, sir. If it's a public policy, then probably the cost of drug in such a scenario would be more helpful, sir.
Correct, correct. I think, Naresh, how much time do I have? 5 more minutes?
5 minutes, sir.
Okay, so I think this is my last question to the panel, and I'll have all of them answer this question and also have my super panelists answer this question. So, Vishnu, in which patient you would use asciminib unequivocally, without hesitation?
Sir, where
One scenario I've already told you, T315I mutation. In addition to that,
all
without feeling guilty about the cost and all that.
yes, sir. So if you like keep the cost aside, sir, then definitely asciminib for all patients. If you like keep the cost aside.
So
Otherwise,
you are a spoiled hematologist. You get daratumumab at the snap of a finger and asciminib at the snap of a finger. We don't have the luxury. Naresh, do we
otherwise,
have
sir,
that luxury?
2+ line failure, sir. Three
Okay,
line of
very good, very good. 2 lines of TKI, suboptimal response. That
yes.
is an unequivocal indication. Anything else?
So
T315.
just a little shift. One line failure will be more uh, preferable or the dream choice, sir.
Dream choice. Dream choice is about right. So Vishnu, Vinod, would you like to comment? What would be your unequivocal indication for using asciminib?
Post 2 lines.
Post 2 lines and T315I, yes? Manoj, anything else in addition to these 2 points?
No, sir, I will I can use Vishnu regimen if asciminib gets generic in all patients.
Or the Novartis substantially
In
reduces the
generic, yes,
price,
yes.
no?
In generic,
Yes.
if generic comes, then I will call it as Vishnu regimen.
Okay, just giving you my thoughts that I would use it without any hesitation in suboptimal responders to second or third line TKI. I would use it if the patient is absolutely intolerant to all TKIs. Once in a while, one in 100 patients, we have like this, and the safety profile of asciminib is the best. And of course, I would use it for patients with 315I mutation provided the patient can afford arrange it. So, ladies and gentlemen, any final comments from my 3 panelists and my one super panelist? Naresh, you start
One
first.
question to you, sir. What is the role of the asciminib in those patients who land to the blast crisis with the second generation drugs? I mean, is it of any use without T315 mutation?
But there are few small studies, but it is like, the other second generation TKIs, you have to treat the patient with acute leukemia-like treatment if it is a myeloid blast crisis. The backbone of the treatment has to be a AML-like treatment. And if it is a lymphoblastic crisis, the backbone and the mainstay of the treatment has to be a ALL-like regime. And of course, a TKI also has to be on board. But the data is very sparse and little, so there are no recommendations on that front. And anything my other experts would want to add to this for Naresh's specific question?
So I have
Sorry,
some different.
one question only. I think you are the super moderator. You have seen the journey. So I just have one question. In terms of like we are targeting asciminib as a stamp inhibitor. So can we like I don't know the data if you have if can we combine with the both one TKI versus stamp inhibitors or because
So that is a very good
curve
question.
imatinib has changed in last 30 years. Probably that much curve is nobody, no other drug is able to change. Just there is slight incremental. But if we combine both the different pathways together, will that be a significant change? What are your thought process on this?
So there is no thought process here. It is a well-established synergy between the two groups of drugs, the STAMP inhibitors and the TKIs. They act at different sites on the CML cell, and there are already studies and reports which are telling us that a combination is synergistic, and the studies are already ongoing in combination with imatinib, in combination with dasatinib, in combination with nilotinib. All the three studies are ongoing. And there was one publication of a combination with nilotinib from the Australian group, Tim Hughes group, at this year's ASH. I forget the name of the study. So some preliminary 70, 80 patient data has already been presented at the ASH. We are waiting for the publication. So this is my last slide, ladies and gentlemen. Life expectancy of CML-CP patients is approaching that of age-sex matched controls. But this is only true if the patient is managed properly. So that is why I have put this only in capitals. If your bread and butter and mainstay is solid tumor oncology, you see one patient of CML in 6 months, please send that patient to a colleague of yours, a hematology colleague or a medical oncology colleague. Otherwise, you will be doing a big injustice to your patient. Our newly diagnosed patients of CML-CP now has several options of treatment, particularly with the availability of generic second generation tyrosine kinase inhibitors, and particularly for patients who have high SOCAL risk or intermediate and high ELTS scores, they should be started on a second generation TKI. Asciminib is again available now. I had made a presentation at last year's EHA. I called it obscenely expensive, and I stick to that still. It is obscenely expensive, and I really hope and wish and pray that somehow we are able to prevail on the industry to reduce the price and make it a little more accessible to our patients. And TFR is and should be a goal for most patients, particularly young patients, and particularly the female patients desirous of having a child. And the choice of TKI will depend on the costs, comorbidities, convenience, and toxicities. So with that, we can close this panel discussion. If there are any burning issues from any one of my panel, please make your point quickly, and then we'll hand over back to Dr. Somani. Thank you very much.
Only one comment that SC4 first was, sir, it was an open label study. So the relative toxicity, what we see are less in asciminib, can be a false impression, sir, because it was not a blinded study. So from perception of single study saying that this is less toxic can be premature, and we have to see further comparative studies, sir. That is
So I actually don't agree to that. We know there have been lots of other studies in the second line and in the first line, and there have been more than 1,000 patients on asciminib, and across the board, across studies, the toxicity profile of asciminib is better than the toxicity profile of all the other studies. So you do need to keep that in mind. That this is this is not a chance of one study. This is a definite observation across the world, across multiple studies, across many patients, that asciminib, as of just now, long-term toxicities we don't know. Like nilotinib, cardiovascular toxicities we discovered after 5 years or 10 years of usage. Long-term toxicities we don't know, but short-term toxicities of asciminib are significantly less than second generation TKIs and also less than of imatinib.
And sir, we have experience of using asciminib in T315I mutations, where dose is actually 5 times
Yeah,
than the normal dose.
that's
So
right.
it is
That is
yes.
again a very major point, that even if you give 200 milligrams twice a day, the tolerability is quite acceptable. Good
Don't
point,
have
Vishnu.
TFR data with asciminib. We don't have TFR data.
Agreed. TFR data we don't have, and there are preliminary reports that it doesn't work in several TKI kinase domain mutations. It produces more mutations, but those are all preliminary findings. But I do agree with you. I'm a conservative oncologist. I change very, very slowly, maybe because of my age. But I also do feel and agree with you that it is possibly premature to jump on the bandwagon and give everybody asciminib. Not only the cost factor, but also the exposure to the drug and the long-term experience. We still need to work on that and have more of that. Okay, Naresh, over to you, and thank you very much. A big round of applause to my
Yeah.
wonderful learned panelists. I really enjoyed this. I hope you enjoyed it also. Thank you.
Thank you, sir, for taking through us the CML quickly and in a crisp manner. And we are really amazed to see the differences in a little bit in the opinions of all the three panelists. Maybe that they are coming from the different background of the patient which they are dealing day to day practice. So with that, we move on to the next session. That is, we are now switching from the hematological section to the solid tumor genitourinary. The first talk is on the endometrial malignancy with the uh, era of the molecular and the precision oncology, and having the various targets in the metastatic or the advanced cancer in the endometrium, like for HER positive patient, MSI high patient, looking at the high incidence of the MMR or MSI, and with the more and more availability of the different PD-1, PD-L1 inhibitor in this setting. So what's new? What's the update in this particular field? We have with us one of the very popular medical oncologist of the country, I must say, Dr. Tarachand Gupta, from Bhagwan Mahavir Cancer Hospital. And only request to Dr. Tarachand will go to that. Please stick to the time so we can have a in the last quiz for our students well in the time. Over to you, Dr. Tara.
Thank you, sir, for yeah, almost an introduction of uh, beyond the expectations. And sir, again, your expectations are high for the timely bound presentation, because GSK has provided 60 slides for the 15-minute
Please,
duration.
please
So I
use,
will
use
try
your
to, yes,
use
yes,
your
I will try
wisdom
to,
and finish in the time. Let
yes,
them
sir.
have the 60 slides, but the request
Yeah.
will go. You please stick to your time.
Okay, sir. So now we are going to discuss the advancements in systemic management of advanced stage
Please make the
endometrial
full
cancer.
screen. Please make the full
Oh,
screen.
yeah, yeah.
Sorry, sorry,
So,
sorry.
yeah. So we will be discussing the advanced stage endometrial cancer. So we will try to finish in time. So this is the GSK sponsored session. This will be my discussion point, the rational strategy and the landscape for the immune checkpoint inhibitors. Immune checkpoint inhibitors in plus chemotherapy, Ruby Keynote 868 DOE trial. Immune checkpoint inhibitors in second line endometrial cancer, Garnet and Keynote 158. So this is the burden of the endometrial cancer in India. That is around more than 17,000 cases per annum as per the 2022 Globocan data. So primary treatment for the advanced stage is the most commonly is chemotherapy or chemoimmunotherapy or chemotherapy plus TKIs. So these are the NCCN guidelines, which are suggesting that in adjuvant setting in stage 3-4, we can add the immunotherapy along with the chemotherapy with the benefit of PFS, not the OS still yet in the adjuvant setting. And for the advanced setting in recurrent disease, these are the preferred guidelines where we can add up on the immune checkpoint inhibitors like pembrolizumab, dostarlimab without any marker, and in DMMR setting, you can add the durvalumab in the first line setting. Otherwise, in the proficient MMR, TMB high, and MSI, other biomarkers which guide immunotherapy in endometrial cancer. So this is the history of endometrial cancer. I think we should move on because this is already discussed many times in many meetings. So this is the immune checkpoint inhibitors monotherapy where the Garnet trial was discussed. Sorry. Yes, so this is the Garnet trial is the basket trial. Both are the basket trial. Endometrial cancer was one of the cohort, and the setting is the previously treated patient with the DMR and MSI high. Single arm study with the standard dose of dostarlimab and pembrolizumab. Number of patients were quite good in the dostarlimab Garnet. It is 143, and in pembrolizumab it is 90. So primary endpoint was overall response rate and duration of response. Secondary endpoints PFS, OS, immature-related overall, immune-related overall response rate, and immune-related disease control rate, PFS, and DOR. So this is the median age around 65 in both arm, and disease staging FIGO 1 or 2 around 43.4% patients, while it was and M0 is around 4 keynote patients. It is only 5% of the patient. FIGO 3 or 4, it is 56.6, and M1 patients are 95%. Prior lines of therapy, most of the patients were in second line. So ICI monotherapy in the second line endometrial cancer primary endpoint results, where the overall response rate was around 45.5% versus 48%. And this is the complete response rate. It is around the 29.4 versus 34. Sorry, 16 versus 14, and partial response 29 versus 34, and stable digits 14.7 versus 18. So median duration of response not reached in the both trials. Probability of maintaining response at 12 months, it is 93.3 in the Garnet versus 88 in the Keynote 58. At 24 months, it is 83.7, and it is 73% in the Keynote 158. So this is the secondary endpoint of PFS. That at the 3 years, it is the 40.1% versus 48.4% in favor of dostarlimab. In the pembrolizumab arm, it is around 37. I think it is number of events is 79 versus 45. That is 13.1 month PFS. So probability of overall survival, it is not reached in median OS is not reached in monotherapy in the immunotherapy arm. That is at 3 years, it is 58.4% and dostarlimab, and it is number of events, I think 79 versus 29 in pembrolizumab and 27.2 month median survival versus not reached in the pembrolizumab. So this is the Ruby trial. That is the phase 3 global double-blind randomized placebo-controlled trial evaluating the efficacy and safety of dostarlimab when the patient of stage 3-4 disease or first recurrent endometrial cancer with low potential for cure by radiation therapy or surgery alone or in combination. Carcinosarcoma, clear cell cirrhosis, or mixed histology permitted. Naive to systemic anti-cancer therapy or had a recurrent or progression disease 6 or more months after the completing systemic anti-cancer therapy with ECOG performance status good and adequate organ function. Patients were randomized 1-to-1 dostarlimab plus chemotherapy versus placebo plus chemotherapy followed by the maintenance till the progression. Primary endpoint was the progression-free survival and overall survival. Secondary endpoints PFS, PFS2 overall response rate, duration of response, disease control rate, health-related quality of life, stratification MMR versus MSI status, prior external pelvic radiotherapy, and disease status. So staging-based inclusion criteria, it was subjects has primary stage 3A to 3C1 disease with presence of evaluable or measurable disease as per the RECIST 1.1. Subject has primary stage 3C1 stages with carcinosarcoma, clear cell, serous, or mixed histology containing 10 or more than 10% carcinoma sarcoma, clear or serous histology regardless of presence of valuable or measurable disease. on imaging. Subject has primary stage 2, 2 or stage 4 disease. Subject has first recurrent disease and is chemotherapy no. Subject has received prior neoadjuvant, adjuvant systemic chemotherapy and had a recurrence or progression disease within more 6 months after that completing. These are the baseline characteristics of the
ताराचंद सर वॉइस नहीं आ रहा है आपका. कैन यू प्लीज लाउड?
Dr. Tara sir, sorry to interrupt, but your audio is not there. Hello, Dr. Tara sir. Dr. Tara sir, sorry to interrupt, but your audio is not clear.
Am I audible or not, Naresh sir?
Now you're audible, sir. Now you're audible.
Okay, now I'm. So now again, moving. I don't know why it was done. So an updated overall survival in MMR proficient and MSI stable patients, risk of death was reduced by 21%. That means hazard ratio was 0.79. At the median duration of follow-up 37.5 months. At 2 year, it is 53.2 versus 66.5%. That is almost 13% absolute difference. At 3 year, it is 7% difference in overall survival. So this is the forest plot where nearby all the subgroups were benefited from the experimental arm, that means Posterlimab, except that no disease at baseline, why it is there. So endometrioid carcinoma, it is, and other both histology, all the histologies were benefited. So in DMMR population, overall response rate was 38% versus 40% in the Dostarlimab, and in proficient MMR, it is around 111 patients versus 102, and in the intention to treat, it is 149 versus 142. Overall response rate percentage 77.6 versus 69% in favor of Dostarlimab. In proficient MMR, it is 68.1% versus 63%, and in overall population, it is 70.3% versus 64.6%. 8%. Duration of response more than 12 months, number it is 22, and DMR versus 7, and in PMR it is 38 versus 22, while in intention to treat it is 60 versus 29, that is almost double. Adverse events, any event that is around 100% patients has any event, or in the both arm, any event related to trial drug or placebo, it is around 97.9 versus 98.8, and related to dostarlimab or placebo, it is 84.2 versus 74. But for the grade 3 or more adverse events with the related to dostarlimab, it is 33.2 versus 19.5 with the placebo. That means 33% patients had grade 3 or more events. Any serious event related to dostarlimab, it is 12.4 versus 6.9%. Immune-related events related to trial drug, or it is 38.2 versus 15.4. Events leading to that, it is 2.1% versus 0%. So now the keynote 868 NRG GY018 study design, where the pembrolizumab was tested in the histologically confirmed recurrent or advanced stage 3, 4A, 4B endometrial cancer with good performance status. Results
Dr.
of
Tara,
institution
may I
MR.
request you to move on little on the last point to give the message, because we are short of the time.
So median duration of follow addition of pembrolizumab. So I think these are the summary of DUO-E trial was also they're testing the durvalumab in endometrial cancer in the DMMR population. Then intention to treat, it is this is the DUO-E safety profile. So Ruby K9 868 and DUO-E trial design. These are the trial designs. Trial characteristics, treatment arm in Ruby, it is dostarlimab plus carboplatin paclitaxel. Keynote 868 pembrolizumab plus chemotherapy, and DOE it is durvalumab plus orvalumab or olaparib plus chemotherapy. छौंक लगा दिया मरीज का. Control arm placebo plus that means both were having placebo, all were randomization 1:1. Number of patients 245 versus 249 in Ruby, 400 patients per arm in Keynote 868, and DOE it is 239, 238, and 241. And DMMR treatment 53 and 65, 112 and 113 in Keynote 868, and DOE 484649. Primary endpoint PFS, and secondary endpoint rest. So trial characteristics, histology-based inclusion criteria, that in Ruby trial, subject had the primary stage 3 and 4. So we had the inclusion criteria already. So these are the baseline characteristics in all the patients. So FIGO 3 stage was around both 75%, 30.6% in the Ruby versus 26. From Keynote 868, stage 3 patients were 18% around, and DOE it is around 5% patients. PFS in first line therapy in PMMR population. I think dostarlimab has the better results, around 18.8 versus 28.4 at 2 years, while at around 12 months it is pembrolizumab. It is not showing at 2 years survival here in the curve, and durvalumab it is around 15 month versus 9.9 month, and with a hazard ratio of 0.57 in durvalumab plus olaparib, while it is single 0.77 in durvalumab alone. So overall survival data for subgroup yet to mature, only 28% maturity at the time of publication in the durvalumab, while in dostarlimab and pembrolizumab overall in survival at the 3 year it is 41.9 versus 48.6. At 3 year, 2 year, it is nearby overlapping in pembrolizumab, that 8.8 versus 8.4 month follow-up, with the median OS is nearby same, 27.96 versus 27.37. So PFS of 3 IOs in first-line endometrial cancer, Ruby, Keynote 868, and DOE. So 25.4 month was the follow-up in Ruby at the highest, with a and median PFS not reached versus 7.7 in all the 3 IOs. And hazard ratio of PFS in PMMR and 9.9 versus 7.9 month, that is 0.76, while it is 13.1 versus 8.7 month in Keynote 868, and DOE it is 0.57, durvalumab 9.9 versus 9.7 month. So we have seen time and again, somehow all IOs are not the same. Sometimes immunotherapy takes a little longer, and as a result of all ICI, especially in advanced stage, OS matter the most. The benefit of ICI plus chemo in first line endometrial cancer is more pronounced in DMMR or MSI high patients. In the PMMR MSI stable cohort, all the three trials showed a 10% improvement in PFS compared to placebo arm. The magnitude of PFS benefit between ICI was the highest in Druva plus olaparib arm 15 month, followed by 13.1 month in Pembro and followed by 9.9 month in the dostarlimab. The control arm's PFS was comparable between the study. However, the slight increase in median PFS did not reflect in the median OS in PMMR population, where dostarlimab had the highest median OS of 34 months, followed by 27.9 months in the pembrolizumab. The DOE trial had only 28% data maturity. In the second line, endometrial cancer DMR patients get maximum benefit of IO. Thank you.
Dr. Tarachan, for a little lengthy, but giving the clear idea about the present concept of the various immune checkpoint inhibitors in the first line and second line, which we often try to use, and interestingly, both in the deficient as well as in the proficient patient. If any comment and question you can have in the chat box, we move on to the next session by Dr. Abhishek Raj from Medical Oncology from Faridabad. And as we have the stage 3 NSCLC patient, non-operable, non-resectable patient, we try to give them the chemo RT plus durvalumab. And this durvalumab has been studied in the various way upfront also, concurrent with chemo, or followed by chemo RT also in a responding patient. Other drugs has also been studied. So where does this particular scenario stand, and what is the role of the durvalumab in this setting? And the newer trial which has come in this field is the Skyscraper 03. So over to you, Dr. Abhishek Ras.
Thank you, sir. Thank you for making my job easier, and thank you for the kind invitation. So, as you rightly mentioned, stage 3 NSCLC has progressed a lot. It started with a dismal outcome of utilization of sequential therapy, definitive RT, then came concurrent chemo RT for patients who are unresectable disease. Despite that, the outcomes remained dismal, and it was slightly changed by the addition of durvalumab maintenance for the patients who had response after achieving a CR or PR post CCRT. And we all have been using the data of Pacific for the past few years. You rightly mentioned that it has also been studied in concurrent followed by maintenance setting in durvalumab, which failed to show additional benefit over and above durvalumab maintenance alone. So Skyscraper was something which was presented in ESMO 2025 this year. So it is a proof of concept phase 3 open label randomized study of atezo plus a new drug tiragolumab versus the standard of care durvalumab in locally advanced unresectable stage 3 NSCLC after standard platinum-based concurrent chemoradiation. I think the PI is from Poland, and it's a multi-center study from right across the globe. So these were the declaration of interest of the authors. Background we have already discussed that 1/3 of the patients of non-small cell lung cancer, they present with stage 3 disease. In India, this number may be slightly higher. Consolidation durvalumab treatment is the standard of care according to the Pacific trial. We usually use either 10 mg per kg every 2 weekly or 1500 mg every 4 weekly for 1 year. Disease recurrence is still an unmet need, although it did lead to an improvement in survival and but still, the 18-month PFS rate for durvalumab was 44.2%. So this is still an unmet need for a lot of these patients. So what is a TIGIT? TIGIT is an immune checkpoint target. It plays a role in cancer immune evasion. Tiragolumab is a human anti-TIGIT monoclonal antibody that augments anti-tumor responses when it is combined with other checkpoint inhibitors. And this is what was tested by Skyscraper 3, that whether if you're adding something else to the TIGIT, whether it leads to improvement in the outcome or not. So this was the study design. So it included stage 3 NSCLC patients who did not progress after definitive platinum-based chemoradiation, who had received at least 2 cycles with a known PD-L1 status. This is where it was different. Although the all-comer patients were included in the durvalumab study, this required the patients to have PD-L1 status known. good performance status patients. It excluded patients of EGFR and ALK. They were randomized 1:1 after 6 weeks. Within 6 weeks, to tiragolumab 840 mg every 4 weekly plus 1680 mg of atezolizumab every 4 weekly, or durvalumab 10 mg per kg 2 weekly, or 15 mg 4 weekly. So the primary endpoint was your PFS for tiragolumab plus atezolizumab versus durvalumab in PDL1 positive population. And if the statistical significance was reached, then they changed the primary endpoint to all-comer patients in PDL1. These were the stratification factors, which is ECOG-PS, PDL1 status, staging, histology, and then there were your other secondary endpoints. So if we talk about the baseline characteristics in PDL1 all-comers, you can see they're fairly matched in both the arms. You can see majority of the patients are smokers, either current or previous, almost 95% of them. 50% of the patients had PDL1 less than 1%, and 50% had more than 1%. Majority of the patients were stage 3 or stage 3B. Squamous histology comprise the majority of the population, around 60%. And you can see that majority of the patient had either PR or stable disease, which is also equally matched. So if you carefully look at this study, even in the PDL1 positive population, compared to durvalumab, I think the addition of tira plus atezo, it did not add any significant benefit. You can see the PFS numbers were virtually the same. There was no difference in the p-value. There was no, the stratified HR was just 0.96. The curves are not separating. If we talk about the secondary endpoint of OS also, you can see here again the curves are not separating. The number of OS events are virtually the same in both the arms, and the median PFS here was 19.4 months and 16.6 months, which was not significantly different. 12-month and 24-month PFS rates were also nearly the same. Similarly, 12-month and 24-month OS rates were also similar for both the arm. If we talk about all comers, again, you can see the curves are not separating. So it is a negative study. The the median PFS for all-comer patients was 14.2 months versus 13.8 months, inherently indicating that these are slightly poorer prognosis patients. And secondary endpoint of OS also, they are also the same at the time of presentation. Coming to the safety summary, you can see here that the treatment-related adverse events were slightly higher, percentage-wise slightly higher in tiragolumab plus atezolizumab, which is 80% versus 67%. But grade 3 to 4 adverse events were nearly the same. Grade 5 adverse events, there were 2 deaths in atezo-tira arm, while 7 deaths in the durvalumab arm. The causes of deaths have not been mentioned. If we talk about the adverse event of special interest, they're also nearly the same, which is 10% versus 8.7%. And the requirement of steroid is slightly higher with tira plus atezo. So these are the standard side effects, probably indicating either radiation pneumonitis or immune-related pneumonitis, and your standard other immune-related adverse events that you can see, which is seen in this trial. So coming to the conclusion, so Skyscraper 3 did not meet its primary endpoint, which was initially designed. So with tiragolumab plus atezolizumab, it was not superior to durvalumab in patients who have been treated with definitive CTRT in stage 3 disease. And although it demonstrated a tolerable safety profile, which is consistent with previous observation for the combination, and there were no new safety or unexpected signals. So I think after the conclusion of this study, it does not change our standard practice that we have been following for treatment of our stage 3 non-small cell lung cancer patients. So with that, I'll conclude my talk. Now over to the organization, and thank you, Dr. Naresh, sir.
So with the only caveat that after understanding the various mutations, especially in the early stage disease, we are now trying to exclude all mutation positive patients in the clinical practice.
That's right.
That is, I think, the positive change has, or the rightful change has come. So moving to the next session, especially if I say in the light background of the understanding the role of the local radiotherapy in the metastatic prostate cancer, especially in the low volume disease, that it is improving the results substantially And with the data availability that in the slow progressing TKI positive patients in the lung cancer, if we give the local radiotherapy and continue the TKI drug, especially in the EGFR positive patient, probably we remain on the same drug for some more time. So with that background in the mind, I think that was the basis for the newer trial, understanding the role of the local radiotherapy in those NSCLC patients who are EGFR positive upfront in the metastatic setting. And to have highlight on this particular trial, we have with us Dr. Meetu Jain, who is senior consultant radiation oncologist at the HCG Cancer Center, Jaipur. My colleague from HCG Jaipur. Over to you, Dr. Meetu Jain.
Thank you, sir. At the outset, I would like to thank Naresh Somani, sir, and the organizing team. So, I will be presenting a phase 2 randomized study of osimertinib with or without local consolidative therapy for metastatic EGFR mutant non-small cell lung cancers. So, as we all know that most of the EGFR mutated metastatic NSCLC patients treated with EGFR TKIs, they eventually develop the resistant and disease progression. So that local consolidative therapy, either with the radiation or surgery, it improves the outcome in patients with oligometastatic NSCLC. And the rationale behind it that combining EGFR TKIs with LCT, it may eradicate the resistant clones, and that is why it delay the systemic progression. However, prospective randomized evidence evaluating the role of LCT in combination has been lacking. So this study was a randomized multicenter phase 2 trial in which they have compared osimertinib with osimertinib plus local consolidative therapy, and the patients were included with locally advanced metastatic NSCLC with PS0 or 1 with measurable disease, TKI naive patients, and those patients who has received generation 1 first or second, but no third generation TKIs. And they were stratified accordingly, TKI naive versus prior first or second generation TKIs, number of metastases less than 3 or more than 3, partial response versus stable disease, and the presence or absence of brain metastasis. So after giving an induction osimertinib for 6 to 12 weeks, they were randomized 1-to-1, and the one arm received only osimertinib, and the other arm received osimertinib plus local consolidative therapy. And the primary endpoint was progression-free survival, and the secondary endpoints were safety of osimertinib and local consolidative therapy, overall survival, and the PFS in less than 3 months and PFS in TKI naive patients. So the statistical analysis, the study had 80% power to detect an 8 months improvement in median PFS time with a one-sided type 1 error. And the PFS was calculated from osimertinib initiation date to the date of progression or death. So demographic and baseline characteristics in both the arms, they were comparable. The median, right from the median age, and the most common population were women, was approximately 66%. And the most common EGFR mutation was exon 19 deletion. And 95% patients were TKI naive in both the arms. And the number of metastases at baseline was approximately 69 to 71% in both the arms. If we talk about response to the induction osimertinib, it was approximately in the range of 68 to 71%. So most of the patient, like 43% patients had 6 to 10 number of metastases, and 29% were there who had more than 10 metastases in number. So local consolidative therapy approach different. 58% patients were treated using radiation therapy, whereas 32% were treated with surgery, and 9% of the patient received both surgery and radiation as local consolidative therapy. And there are various surgical procedures, right from the lobectomy till the segmentomy were used, and radiation modalities, VMAT, SBRT, and 3D CRT were used. So treatment-related adverse event, So most common adverse event was the skin disorder in both the arms, and it was followed by paronychia, dyspnea, diarrhea, and cough. And grade 3 adverse event was seen for hyponatremia in both the arms. So LCT specific adverse event, it was most commonly seen was dyspnea, 26% grade 1 seen in the LCT specific patients. The progression, coming to the progression free survival. So these are the Kaplan-Meier curves showing that the median progression free survival, it was 17.5 months in the osimertinib arm, whereas it was 25.3 months in osimertinib plus LCT arm. And if we talk in context with exon 19 deletion versus L85R progression-free survival, so among osimertinib arm, it was 22.4 months, where in combined arm, it was 39.8 months. Those patients who has less than 3 number of metastasis, the progression-free survival was in osimertinib arm, it was 22.4 months, and in the combined arm, it was 33.1 months. Whereas where the number of metastasis was more than 3, it was 15.9 versus 19.7 months.
Slides are not moving. Slides are not moving.
Not moving, sir?
Yeah, now it's moving.
Okay, sir. So at the baseline, 71% patient had polymetastatic disease versus 29% patients had oligometastatic disease. After the induction osimertinib, 13% patient had induced oligometastasis, and afterwards they were randomized to receive the local consolidative therapy, and the 100% of the oligomets could complete the local consolidative therapy, and among polymetastatic disease, 56% patient could complete the local consolidative therapy. So when we compare the progression-free survival in polymetastatic disease, those patients who completed the local consolidative therapy, the median progression-free survival was 27.9 months, where those patients could complete only the partial treatment, the median PFS was 14.5 months. So completion of the local consolidative radiotherapy is important. So to conclude, in patients with EGFR mutant metastatic NSCLC, osimertinib plus LCT improved PFS compared to osimertinib, which is 25.3 versus 17.5 months. The benefit of LCT was observed across disease burden groups, including patients with polymetastatic disease. Like complete LCT was achieved in 59% of the patients who presented with polymetastatic disease, with median PFS 27.9 months. The extent of consolidation, complete versus partial, it better predicts the benefit than initial metastatic burden. The no excess toxicity was observed. In particular, there was no increased rate of pneumonitis beyond that expected with thoracic radiation. So these findings supports osimertinib plus LCT as a safe and effective strategy to extend the disease control and delay the systemic progression in advanced EGFR mutant NSCLC. Thank you, sir. Thank you.
Small question in my mind, maybe that I have missed somewhere. So how the patients were chosen between the two arms, RT versus surgery? It was the randomization, or it was based on the T assessment or the tumor size assessment?
Sir, I did not get the question. I did not get the
Patients
question.
were given radiotherapy and surgery both. Few
9%,
patients received
in 9% of the patients, they were treated with both the therapies, radiation plus surgery. And in above more than 50% patients, 58% patients only radiotherapy, and 35% patients treated only with surgery.
So any particular indications of using the surgery, like a small tumor went for the surgery, little larger like T3, T4 kind of the tumor went for the radiotherapy? Any, they have given the way of
Mm,
selecting the patient? Because
no, sir,
in
there is no.
metastatic disease in the clinical practice, hard to sell the idea of the surgery.
Yes, sir. But mm, they have done like from the conservative surgery means the only the lower surgical resection up to the segmentectomy. So they have done these kind of surgeries.
Dr. Akhil, can I ask you, would you like to do this sort of the approach with the first or second generation drug like Gefitinib?
Yes, sir. Actually, sir, we have already designed a trial of PEM carbogef. That means the regimen which we most commonly utilize with or without radiation. That is related to thick we're looking at. In that, we have kept it very simple. It is not about addition of surgery. It is about consolidative RT to the local site. And we have not kept so polymetastatic disease more than 10 sites of mets. I don't think it makes sense actually. There is a strong biological rationale to consolidate in patients with there is disease is confined to either lungs only, that is thorax only, or some bony metastasis. So we need to select the patients well to get the best possible benefit of added radiation. I have a radiation oncology background, so I have the knowledge of both the words. So that has helped me somewhat. So I will be there's a panel discussion which I will be conducting on this points only, and the North Star is the main discussion in that panel discussion, sir.
Okay. So thanks, Dr. Mitujan, for the wonderful presentation. And over to Dr. Akhil Kapoor. I must say, celebrity name in the field of the medical oncologists across the country, with the crystal clear ideas, whether it's the panel, whether it's the moderation, whether it's the presentation, whether it's designing the clinical trials, whether it is the conducting the pharma-oriented clinical trials. He is well known in all these sort of the fields. So, requesting you to go ahead with your panel discussion and invite your panelists also.
Sure. Thank you. Thank you. Thanks, Naresh sir, for giving me this opportunity. I request the panelists, Dr. Deepak Gupta, Deepak Shukla, Dr. Vikasa Sati, Dr. Bhavesh Polaria, Dr. Charachan Gupta, Dr. Ankur Punia, and Dr. Rahul Rai to be there. We'll do a very short and quick panel discussion. The North Star is worth discussing actually. We'll just touch upon Skyscraper. That is a negative trial. We'll just touch upon it. North Star is definitely one of our idea of choice here to discuss. So, osimertinib definitely accessible to a large number of our patients. In fact, at Varanasi, the EG positive rate just crossed 30%. So out of 100% of the patients. So that is first time the EGFR positive rate in the last few years have crossed 50% at our institute. And this is confirmed by both NGS and RT-PCR actually. So there is no doubt about it, whether it is false positive or pseudo false positive. Bhavesh sir, any comment on that? EGFR positivity, you have idea of both North India and South India because you work across Kanpur and as well as South India. So that's the best idea you can give some perspective from the same.
Definitely. I mean, the more we are doing NGS, the more we are picking up EGFR, not only the common ones, even the rare ones, even exon 20, exon 18. So more and more EGFR we are able to pick up. So that is a real scenario. If we are going for only IHC based things, we are actually missing many of them. So I think NGS is the best way to go and to pick up all from 18 to 21, at least everything has to be known.
Yeah. Thank you. Thank you, sir, for your comments. So, rapid comment from Dr. Deepak. Dr. Deepak, in your patients who are coming with EGFR exon 19 or 21, the standard mutations, in how many patients out of 100 you are able to give OC with or without chemotherapy versus PEM carbogef or JEF alone? Rough distribution. This will vary across the practice, but just wanted to get a rough distribution.
In my practice, we see a lot of panel patients. So, means almost 60-70% patients we are able to give osimertinib with chemotherapy or even osimertinib.
Okay.
And
So
remaining
that's
possibly combination of pemetrexed carboplatin with gefitinib is
okay.
what we are using.
Okay, so that's a good number actually for 60 to 70% being able. So it's like a dream for most of us actually. So thanks a lot for your comment. Tarchan boss, any similar percentage or somewhat difference? You are not audible, boss. Tara boss. In the meanwhile, I will request Vikas boss to comment. Vikas, Dr. Vikas Asati.
Yes.
Yeah.
So I don't know if you are asking for the true osimertinib,
Yeah,
then
yeah,
that
yeah,
number,
true.
yeah. So
Yes.
that number may be less than 5%, maybe 2 to
Okay.
3% for me.
Okay, somewhat very close to our own data. At TMH Varanasi, we have data of around 1,000 patients who have received EGFR directed treatment. Out of that, the innovator osimertinib was affordable by around the 80 patients only out of 1,000
Yeah.
patients. So
Yes.
somewhat similar data, I think, is there. So all of us are happy to utilize PEM carbo, Jeff. Any doubt or still any concerns? I will request Dr. Abdul to comment.
Yeah, I'm very comfortable since the study has come. I am using for patient who cannot afford osimertinib. JEF
Okay.
plus chemo is the preferred regime. Only if patient refuses chemotherapy, otherwise JEF chemo my preferred.
Okay. And very rapid comment on OC plus chemo.
So yes, nowadays I have started in a few patients since the data came. I don't see any much major of a difference of toxicity. I'm quite comfortable for patient who can take osimertinib. I'm happy to combine with chemotherapy.
Okay, great. So I think that is a very fast, rapid adoption now, especially in patients with mutations which are there. We see a lot of P53, we see a lot of PIK3CA, CDKN2A. These mutations are actually reducing the survivals that we know about. Now, one more rapid comment about this trial and this idea. So this trial tried to take all the patients actually. They had uh, 6 to 10 meds, more than 10 meds. So we have designed a trial of PEM carbogef, and we have also allowed osimertinib in a subgroup of the patients. So there will be some stratification for patients receiving, because it will be difficult to conduct separate trial for osimertinib and gefetinib. So we are kept in a stratification factor. So and the trial will be a larger one. It will be close to 300 patient trial, and we expect to recruit within 1 year because of the sheer number of the patients we see here. And definitely we'll try to include TMH Mumbai and some other centers to make it multi-centric. So any comment on whether we should include this polymetastatic patient more than 10 patients, 10 minutes or not? Any comment from our dear panelists? Any would like to pitch in and comment about it?
So I think, Bhavesh here, I think beyond
Yes, sir.
3 to 5 meds becomes very difficult, especially if they are in different organs. So what you commented before the panel, that was absolutely spot on. If they are restricted to the lung or restricted to the thorax, we still can manage it, whether it is 5 or 10. But if it is outside the thorax and multiple organ involves with more than 3 to 5 sites and lesions, it is becoming very difficult. Even if you are going with a curative intent, like the way they do it, either surgery or radiation consolidation, these patients recur back very fast. So we have done this in past. We have been speaking with Dr. Kumar Prabhash and trying to do such things in oligometastatic disease outside the thorax, and in miserably failed. That is what we discussed, and sir said that you have to wait at least for 6 months to 1 year before trying to consolidate such kind of patients.
Yeah, so that's a very important point. Actually, I completely agree. That is an important message. Yes, definitely. And there's a comment from Dr. Vinod about the SPRT in brain. Up to 10 can be done extracranial, I suppose. SBRT is possible at 10 sites sometimes. Okay.
Can I make a comment
Even,
here?
Yes, sir, please.
Yeah, if you delay it for a long period of the time, let's say beyond 6 months, I believe that by that time, few patients will start developing resistance or change in the histopathology and other resistance patterns somewhere, either at the primary site or somewhere at the metastatic sites. So with the very idea of that you are trying to eliminate or eradicate the resistance clone, probably will be defeated by delaying it sort of unnecessarily. That's my thought process.
So in patient with polymetastatic disease, just looking at it will help us to get us the biology of the disease, whether the disease is responsive or not. In that case, it is just selecting the biology. Good biology patients, definitely some consolidation might help to further delay the resistance. So I think that is the contention here. Bhavesh sir, correct?
Yes, 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 absolutely, absolutely.
Yes, Dr. Ankur, yeah, yeah.
Yeah.
Tarabas, yes, please.
I think the polymetastatic disease is the disease where we can combine Flora 2 plus North Star.
Yeah, so in fact, we will never design a trial now, investigative trial
No,
without
that is the
chemotherapy.
thing that where we can use the clinical like that the patient now the disease is contained after the giving the Flora 2, and now you can use the consolidated therapy and continue with the osimertinib alone or chemo plus osimertinib because these trials will never happen again. These will come to the only the clinical judgment at the time of in the clinic only.
So
Even
what we
even
have
in
thought
this
of, yeah,
Sorry, even in this North Star trial, the outcomes for the patients was best when the local consolidative treatment was being able to give to all sites of disease. So even in polymetastatic site, the outcomes were only good. It was good, particularly in exon 19 and also in other subset when at polymetastatic site, local consolidative treatment was possible at each site.
so it is matching somewhat with Saber Comet results actually. So I completely agree. And this is an area where we have a lot of patients throughout the country, not only at Varanasi. I think it's a very good idea to conduct such a study. It will not be a too expensive study with expensive drugs, but yes, we can add something. What we have decided actually, I would just like to get the opinion from the all the esteemed panelists. We have decided that in our Flora 2 regimen, what is the problem? Continuing pemetrexed maintenance keeps on giving us toxicities and patient is also not happy. So what we have decided, we'll start with PEM carbo osimertinib, or the patients who are not affording osimertinib will give PEM carbo JEF, that there will be stratification for JEF versus OC. Also, the patient will complete 4 cycles of PEM carbo, and then after 4 weeks of that, the patient will be given a consolidation RT, and there will be no pemetrexed maintenance. So that is what we have decided in our study. So that will give us the benefit of both. That is one of the thought process, but I will be happy to take
Dr.
comments.
Akhil, one comment. So now
Yes.
we have data from Compel also. So there could be two arms. You can start with osimertinib. You can add pemetrexed carboplatin and means in Compel actually they have added pemetrexed carboplatin at progression. But
Okay.
means this particular trial is an option for patients. We have all seen patients who are pretty sure they do not want any form of chemotherapy.
Yeah. Yeah.
So this trial adds an option for those patients.
Okay. Well, that's definitely makes
We have
sense.
seen this type of data in small cell lung cancer, sometimes in squamous cell lung cancer and prostate cancer also, where we are using the consolidative RT and to get the PFS benefit at least.
That definitely is an idea. So, Dr. Ankur, your comments on this? What should be the best way forward if you see all these designs, a mixture of these two versus going with very standard regimens and then adding radiation?
I still don't agree that whether we should omit pemetrexed post-consolidative RT because that's the sort of standard. Yes, we don't know how much addition benefit it adds the osimertinib post-consolidation. We don't have, but yeah, it's a noted thing. The other thing which I think will make a lot of sense, will might be eventually with the future, is for patients to give 2-3 months trial of osimertinib, and the best thing to do eventually will be ctDNA or do a liquid biopsy. What I feel for patients who are still positive are those patients who are, I think, are unlikely to benefit from like a consolidative therapy and will not be good candidates for consolidative therapy. For patients who might be ctDNA negative or any EGFR becomes negative, those patients might be good to consolidate all the metastatic site, so selecting biologically rather than just on number of metastasis.
Yeah. So for ctDNA, I think ctDNA will be somewhat costly. So we have included CFDNA EGFR, CFDNA EGFR in all these patients. So that is very cheap, and we have ddPCR actually. So we'll be doing it through ddPCR, which is quite sensitive. So that is the plan. We'll do at baseline. We'll do after completion of 4 cycles, and we'll keep on doing after every 3 to 4 months. So that is our plan, and we'll tease out the data later if that is giving some meaningful signals or not. So a good suggestion, Dr. Ankur, and I
With
completely
regards
agree
to
with your comments.
safety of osimertinib with radiation, means there was a comment in the discussion also during this ESMO meeting regarding the safety.
Yeah. So actually, this trial had a conclusion that there was no excess toxicity was observed with no increased rate of pneumonitis, which is there beyond that expected with thoracic radiation. So that was a good point actually. So this trial actually gave us a safety data that the osimertinib can be combined with radiation. Otherwise, I was also not very convinced of chances of ILD. So this trial has given me some background that I can defend it in my ethics committee too for patient safety. So this is a good idea to have this combination. I think.
So Akhil, just wanted to ask you from the
Yes.
previous slide, you think three should be the cutoff, three and less should be the cutoff for such patients?
So,
Because
sir,
beyond three, we cannot see much of the PFS benefit.
So, sir, actually, thoracic versus extrathoracic is more important. If
Correct.
it within thorax there are multiple lesions, that is a separate story. If out of thorax there are multiple sites, for example, there is mets in the liver, there is mets in adrenal, there is mets in multiple bones, then that patient is not a good candidate for consolidation. That is what I understand till now. So I think
Correct.
so that thoracic versus extrathoracic will also be one of the stratification factor which we have planned apart from the performance status. So four stratification factors will be there.
I think in future,
Great. Great.
circulating tumor DNA level may guide that what the level we have achieved now, we should use consolidated therapy or not.
Yeah, yes, so I completely agree, sir. So a very rapid comment on the skyscraper. Skyscraper is a negative study. We will not know about it, and nobody will discuss negative study. So just to highlight, any other trial which we are looking at very optimistically to improve the outcomes? Anybody would like to comment on that trial?
Pacific, we are
Pacific
Yeah.
Pacific 8, we are a part of it. And
Okay.
I have seen beautiful results in patients who have at least, gone through. And we came, it is a randomized blinded trial. We came to know only when the side effects of durvalumab started coming in. So what the patient is getting. So basically it is durvalumab versus in the consolidation or maintenance part, durvalumab versus durvalumab plus again an anti-TIGIT domvanalimab. So this the group is the same, but it is still recruiting, so it's too early to say anything. But that is something what we are looking forward for.
Completely agree. So that trial is also recruited at our center, and this is a very beautiful trial. That is a double-blinded placebo-controlled trial. So we look forward. Pacific 2 is negative. We know this skyscraper is negative, but let's see how because Atizo was always a negative study multiple times. Whether Atizo was contributing or anything to that or not, we don't know. So we have a trial of Durva versus Durva plus Domnavalimab. I think that's a beautiful trial, and that will help us to know whether we can do something better for these patients. Any other comments? Because we need to wrap up in view of time. Any final comments from anyone? So I think I tried to summarize the important points regarding these two studies. Back to Naresh Somani sir for further ado. Thank you, sir.
Thank you, Dr. Akhil Kapoor and all the panelists to give the uh, little more insight in the various newer thing which has come in this field. So moving to the next session, we have with us Professor Dr. Sandeep Jasuja, Head Medical Oncology and Medical Superintendent at the State Cancer Institute, Jaipur, well-known figure to all of you. He keeps calling all of us at least annually for the breast cancer and the precision oncology conference. So maybe that invitation goes to all of you for the very next year. Am I right, Sandeep? So he will be talking about the Alcensa in the first line, L positive metastatic NSCLC, final overall survival to you in this study. And we'll be requesting Dr. Sandeep that please cut down your times by 5 minutes so we can move on to the next session well in that time. Over to you, Dr. Sandeep. Dr. Sandeep is not audible to me. Back team, please respond. Slides are also not visible. Yes, sir.
Just I am sharing the slide.
Okay.
Just give me one moment, sir.
Sandeep, you can continue talking.
So good evening, everyone, and just let me give the thanks to our organizer, Dr. Naresh Mani sir, for giving me an opportunity to be part of this meeting, prestigious meeting. And now, just I just I'm sharing my slide, but it's not getting. I'm not getting my slides here.
Back team, are you able to see the problem?
Sir, click on
So
double click on your PPT slide, no?
okay, 1 minute. Getting the slides. So can I share to you?
Okay, Jhalak, can you please upload
Speaker, and I will
from the
share the slides to for presentations.
So give me a 1 second. Jhalak will be uploaded.
So I think that these are the long slides. So I have cut down the slides and I have made my slides. So that's the, I think it will be big challenge for me to compile the slides. Okay, 1 minute. Can I share my slides, please? If you can help me.
Sure.
So how to share now? Is my slide is visible?
Yes, sir. Make it full screen, please.
Yeah, is it visible now?
Yes, sir.
In miniature form, we can see something.
So tech support, can you please help out?
Yes. Now it's visible, I think. So make it from my another mobile. I am seeing my slides. So can I start?
So yes,
Yeah, please go ahead.
we'll start.
So good evening, everyone. Let me give the thanks to our organizer, Dr. Naresh Samani, for doing this excellent meeting. And my this presentation will be focused on the role of alectinib as first-line therapy in NSCLC, ALK positive NSCLC metastasis based on the final overall survival data from the ALEX study. So, to my disclaimer, these slides are provided to me by Roche, and all information intended for the health professionals and aligned with the approval indications. So, coming to my contents of the slides, this will be including the overview of the NSCLC, ALK testing, ALK disease, approved ALK inhibitors, and alectinib itself. As we know, lung cancer remains the second most common cancer globally and the leading cause of the cancer-related mortality with over 2.2 million new cases and 1.8 million deaths annually. It represents a significant public health burden. So NSC constitute more than 80%. NSCLC constitute more than 80% of the lung cancer, with adenocarcinoma being the predominant subset type. This heterogeneity underscores the importance of the molecular profiling to target the therapy. In India, lung cancer continues to be the major cause of the cancer-related mortality, particularly among the men, and approximately 72,000 patients are new cases and 66,000 deaths occurs annually. So that's why the routine testing for EGFR and ALK alternate is strongly recommended in the adenocarcinoma histology, as identification of the oncology driver allows precise and effective treatment strategies. Cell testing can be performed by using ISC, FISH, RT-PCR, NGS. But among the all, the ISC has emerging as an efficiency screening tool with confirmation testing using the FISH whenever it's required. 12 positive NSCLC represent a unique subset, typically seen in the young patient, non-smoker, and those with the adenocarcinoma histology. So if we look at the percentage of the ALK positivity in the Indian setup, it's approximate 7%, but it varies from the 2.7% to the 13.7% depending upon the different region. So several ALK TKIs are approved in the first line setting, including crazitinib, certinib, elkananib, brigatinib, and lorlatinib, and each is supported by the powered phase 3 trials. And coming to the first approved ALK inhibitors, to show the superior PFS is the crizotinib shown in the study of the profile 1014, comparing the chemotherapy, which demonstrated very good progression-free survival, but have limited CNS penetration and had limited CNS penetration. And it also shown the overall significant overall survival, approximately 7% difference survival comparing to the chemotherapy and at a 4 year. So, but it has also significant side effect, mainly in the GI, kind of GI side effects like vision, like diarrhea, nausea, and vomiting, constipations. And also sometimes patient may suffer from the vision disorders. So next drug is the certinib. In a sense, for like crizotinib, certinib also improved the PFS over the chemotherapy, but was associated with significant gastrointestinal toxicity and same diarrhea and gastrointestinal toxicities. Because of efflux transporter system, crizotinib and certinib have limited CNS exposure and allow the brain to remain a sanctuary site for the disease progression. So this suboptimal CNS control highlight on the need for the neo-ALK inhibitors with better penetration and sustainable intracranial activity. So coming to the next drug is the brigatinib, which have also shown very significant improvement in progression-free survival when we compare the crizotinib, and this is 24-month overall PFS at PFS comparing to 11 month in crizotinib arm. And also lorlatinib also shown the improved systemic control in systemic control comparing to a crizotinib, and still the median PFS is not reported in lorlatinib arm comparing to the crizotinib arm, where PFS was seen in 9.1 month. But the safety profile and tolerability remains the key consideration, and treatment-related grade 3-4 event were reported in 66% patient in the lorlatinib arm compared to 39% patient in the crizotinib arm. So now we need for an ideal ALK TKI. The ideal ALK TKI should be demonstrate prolonged PFS, effective CNS control, durable response, and should be a manageable toxicity and safety. So here the lectinib comes in the mainstream. So lectinib is the highly selective potent ALK inhibitor with superior CNS penetration and activity against the resistance mutations. So it has the largest evidence supporting among the ALK TKI backed by AF001 SAM1JP study, JALX, LCS study, and the landmark and most important is the global ALEX trial. So ALEX study enrolled 303 treatment naive patients with confirmed ALK rearrangement and ECOX 0 to 2 patients. And patients were randomized 1-to-1 to alectinib 600 mg twice daily or crizotinib 250 mg twice daily. And stratification was based on the CNS metastasis as the baseline, ethnicity, ECOX status, ECOG status, and major strength of this ALEC was the routinely brain MRI every 8 weeks. So allowing for precise detection of the intracranial progression. The primary endpoint was investigator assessed progression-free survival, while secondary endpoint included overall survival, CNS progression, overall duration, overall response rate, duration of response rate, and safety. So stratification factors include CNS metastasis at the baseline, which is very important in this study, Asian-wise non-Asian ethnicity, ECOG status, and male and female ratio. One of the most unique strengths of this ALK study is that it prospectively will monitor the CNS disease using brain MRI every 8 weeks, enabling accurate assessment of intracranial progression. So the final mature data, PFS analysis of LX demonstrate a significant median improved overall progression-free survival of 34.8 months with alectinib comparing to significant shorter duration with crejotinib. This represents nearly 3 times longer disease control, highlighting the profound impact of the alectinib in delaying the progression. So additionally, if you look at the 4-year data, then it's a 43.7% patient treated with alectinib remains progression free, whereas the event-free survival rates for crejotinib patient was not estimated. This underscore not justify just the improvement, but a sustained disease stability over multiple years.
Dr. Jasuja, may I request you to wind it up and give the final conclusion in the interest of the time?
So I think the important point is the CNS reduction in CNS, 84% reduction in CNS compared to crejotinib, and also 5 years overall survival data from Alexa comes at 5 years, 62%, 0.5% patient treated with elective were alive compared to 45% 5 with crejotinib. So this is one of the highest data of the OS survival. And if we compare the baseline CNS metastasis baseline with or without, then again alectinib surpassed the crejotinib in comparing with the both groups. So alectinib displays stable and manageable safety profile even with long-term use. And most common grade toxicity are just liver enzyme and bilirubin, and this is very safe and effective treatment. So coming to the alectinib highlights, alectinib has demonstrated median PFS of 34.8 months compared to in a first line setting, and this is effective protect against the untreated CNS metastasis, and also is well tolerated and well characterized manageable safety profile that maintain with long-term use. So it is approved in NSCLC first line, and also ESMO also given the first line uh, approval for the alectinib in the NSCLC. So to summarize my study, the alectinib delivers the longest PFS in the first line, ALK positive NSCLC, superior CNS protection with a significant reduction in brain progression, the highest OS, 5-year OS survival reported with this, and durable response with strong safety profile. So therefore, alectinib is not just a treatment option, but the current standard of care for ALK positive metastatic NSCLC in the first line setting. Thank you very much, sir, for giving me an opportunity.
Thanks, Dr. Sandeep. And we tried to cover lot many things in this particular 2 days webinar based on the ESMO. But you all understand that we cannot cover, and to cover few more important landmark trials which has come this year. We have with us Professor Dr. Lalit Mohan Sarma, medical oncologist from Mahatma Gandhi Hospital and Medical College, Jaipur. So he will be covering few more important trials and the presentation this year from the ESMO. So over to you, Dr. Lalit.
So thank you so much, Dr. Somani. Without wasting much time, can you see my screen?
Yes.
Is it visible? Is the screen visible to all of you?
Yes, sir.
Yes,
Yes,
I'll
sir.
make it
Visible
full
and audible.
screen. Yeah,
Great.
it's visible
Thank you.
now.
Thank you so much. So without wasting much time, with thanks to Dr. Somani and team, and INTAS for supporting this activity. Two papers have been given to me. I'll try to wind up as short as possible in the interest of time. So this was the IO serplimumab plus chemotherapy with or without this HLX04, which is a biosimilar of bevacizumab in advanced non-small cell non-squamous lung carcinoma. This ESTROM 002 study was published, and this is the author's declaration. I did not change any slide. So we all know about addition of the immune inhibitor or the PDL1 inhibitor has improved survival outcome in advanced non-squamous lung cancer. We have seen witnessed the IM power 150 that addition of bevacizumab has made some difference, but again when tried in different other setting like apple trial, it was clear that there is no significant benefit of the bev or the addition of bev atijo. Previously also we heard with Dr. Akhil Kapoor's discussion that probably this again is not very good combination. So this ESTROM 002 is the first phase 3 study where they investigated that whether addition of bevacizumab to anti-PD-L1 antibody plus chemotherapy, whether it shows any significant improvement. So with this background, we start, and this is the final analysis they have presented. So this looks a bit complex study design, but if we see on the right side, the induction chemotherapy had three groups. One group had this IO serplimumab plus bevacizumab biosimilar plus doublet chemotherapy. Group B had serplimumab without no bevacizumab, and chemo drug was there. And group C had in fact only chemotherapy. And the maintenance therapy in first group where all the four drugs were given, serplimumab plus pemetrexed plus the biosimilar bev was used. In group B, we can see that serplimumab plus PEM was there. In group C, it was only pemetrexed was there, and this group was allowed to, on progression, to switch to the another group, and these were the endpoints. So the patient disposition, if we see that more than 1,500 patients in total study group and more than 200 in group A and more than 200 in group B and more than 200 in group C. So if we see the baseline demographic details, it is almost matching. Almost 20% patients had brain mets, and we can see that majority of them were adenocarcinoma. If you see the PD-L1 expression, it was that more than or equal to 1 was almost more than three quarters of patients had CPS score of equal to or more than 1. If you see the PDL1, the TPS score was more than 50% in quarter of patients, and more than 50% had at least more than 1%. If we see the overall survival data, this is interesting that we can see the group A, which had all the four drugs, the median OS was 23.7 months, while group B, which had three drugs, no bevacizumab, 26.8 months, and group C, which had only chemo, had 20 months. And here we can see the p-value also was significant. So the group B did better, and if we see the group B was without bevacizumab. They have done subset analysis also, and we can see that the patients who had brain mets, they also had good median overall survival in group B versus group C. And we can see the TPS more than 50%, they did extremely well as compared to the other groups. If you see the progression-free survival, again with the hazard ratio, if you see in group B, it is 0.54 when p-value is significant. So it seems that the biosimilar bevacizumab doesn't make much of the benefit based on this trial. And we can see that even in subgroup analysis of the BICR assessed progression-free survival, the brain mets, again the group B did better, and the group with TPS more than 50%, that group did better. So these were the endpoints that we can see the CR, PR, and and the stable disease, that more than 60% patients in group A, group B, they were doing well. And we can see that overall response rate was also equal in both. Median duration of response was also equal, but there was some difference in the p-value of group B. The drugs were safe, the safety was also assessed, and we can see that more than or equal to grade 3 toxicity was seen in almost 70% plus patients, and half of the patient had serious adverse events. 27% or 20% patients had discontinuation of the treatment, and 10 to 16% patients had death also, in fact, related to various complications. The related to serplimumab, we can see that half of the patient they had significant side effects related to bevacizumab or the placebo, almost 50% here, and we can see the group B which did not receive, some side effects were there. So this all was like about the side effects. So to conclude about this study, they said that the addition of serplimumab, which is available to us also by INTAS with a good patient assistance program, that addition of this IO to chemotherapy significantly improved overall survival and continued to confer improvement in other efficacy parameters in patients who have not received any treatment or who had locally advanced or metastatic non-squamous non-small cell lung carcinoma. Again, the study highlights that the bevacizumab addition to this IO plus chemo combination did not demonstrate further significantly improved OS or any efficacy endpoints overall, and this was discussed in the previous panel also. So both the investigated treatment regimens had manageable safety effects. So they conclude that combination of serplimumab heteronifly with chemotherapy is an alternative first-line treatment option for patients with locally advanced or metastatic non-squamous non-small cell carcinoma. Addition of bevacizumab did not confer any survival or any other clinical benefit. So this was the first paper given to me. The second paper is about again role of induction chemotherapy with serplimumab plus chemotherapy. And this trial again, like the important point was that in stage 3B and 3C non-small cell lung carcinoma, this trial was undertaken where induction chemotherapy was given, and in addition to the chemo, serplimumab was also given. This is the declaration of the PI. So this LungMed 013 study schema, we can see this is the eligibility, which is okay, that patient should not have a actionable mutation. And the induction chemotherapy was doublet chemotherapy with platinum. And along with that, serplimumab 4.5 milligram per kilo was given Q3 weekly, and total 4 cycles were given as induction chemo. Since this was potentially curative intent, so after 4 cycles, they were randomized and they were reassessed based on the tumor board that whether the disease is resectable or still after 4 cycles it is unresectable. Patients who were resectable disease, again they were stratified whether surgery should be done or radiotherapy should be done depending on various factors. And these stratification factors were and after induction chemotherapy and histological types. And unresectable patients again like treated by the MDT based on the event. The primary endpoint was event-free survival. So if we see that this was the schema, that more than two-thirds of patients were stage 3B, one-third was stage 3C, and we can see the PDL1. The N, if we see that one-third of the patient, they have almost less than 1%, 20% had 1 to 49, and around 10% or so, they were more than 50. And histological subtypes, squamous cell carcinoma was the major subtype. On the right side, we can see out of 100 patients treated, 84% patient finished 4 cycles of induction chemotherapy. Out of this 84, 57 patients were resectable, and out of them 57, 50 patients were randomized 1:1, 27:23 in the radiotherapy arm and 21 in the surgery arm. So if you see the efficacy Then the event-free survival, we can see that the radiological response was very good in the and the median event-free survival was 17.7 months. And this showed that the response with the induction chemotherapy was good. This is pathological complete response, and this is major response, that half of the patients they had complete pathological response, and almost 60% plus patient they had the MPR. If you see the event-free survival from randomization for the 50 patient intention to treat, we can see that patients underwent surgery. So if we see almost 50% of the patient, they have undergone surgery. So the important point here is that 50% of the patients who underwent 4 cycles of chemo, doublet chemotherapy plus serplulimab, they were able to undergo surgery. So that remains one important take home with this study. And these were the adverse event, surgery versus radiotherapy. So again, like we all are aware about the side effects, so it was well tolerated. 47% patient underwent VETS chemotherapy. These are different surgical things. These are different complications. So these are beyond the scope of discussion of today about the surgical complications. So they concluded that induction therapy with serplulimab plus chemotherapy converted 50% of patients from unresectable to resectable, and they demonstrated a positive, promising survival outcome. Patients where disease was converted to resectable and those who underwent surgery, they showed a trend towards improved event-free survival compared to those who received radiation. And at the end, they are saying that induction chemotherapy with serplulimab plus chemo, followed by either surgery or radiotherapy, it was largely well tolerated and there was no new safety signals. So with this, I thank Dr. Naresh Somani and team, and I thank INTAS for support, and I thank every one of you for helping us. Thank you so much.
Somani sir, please unmute yourself. Dr. Somani, please
Yeah,
sir,
yeah,
unmute
sorry,
yourself, sir.
sorry,
Yeah.
sorry. So thanks, Dr. Lalit Mohan Sharma, to give this more insight about this particular aspect, and especially when this drug is now available at substantially low price, making it widely available now. I think it becomes important for everyone to understand the newer and newer studies and the implication that how it can be used in our practice beyond what the being understood as a treatment being approved by the DCGI. So it becomes important that can we apply these newer trials, especially which has the robust data. So today's last presentation before we go to the quiz is by Dr. Satyajit Soni. So he will be talking about the this tislelizumab in the management of the NSCLC. What's the ESMO update about this molecule? And this is the another immune checkpoint inhibitor which is available with us, reducing the cost, making it more widely available. So how we can explore more and more about this particular molecule. Over to you, Dr. Satyajit.
Good evening, sir. Thank you very much for providing me opportunity to speak on the today conference regarding role of tislelizumab in the management of NSCLC. My screen is visible?
Visible and audible.
Okay, thank you, sir. I'm proceeding. So we have discussed many times regarding the tislelizumab. It is an humanized IgG4 monoclonal antibody with high affinity in binding specificity for PD1, which is present on the T cell. It blocks the binding of PDL1 and PDL2 to the PD1, and it has unique binding epitopes, binding kinetics, and distinctive binding orientation to PD1 in comparison to the previous PD1 inhibitors like Pembro and Nivo. And the recommended dose of this drug is 200 milligram every 3 weekly till disease progression and unexpected toxicity. So it has many indication globally approved, right from the nasopharyngeal carcinoma in the NSCLC, both squamous as well as non-squamous, and the small cell lung cancer, and in GI malignancy, esophageal squamous cell carcinoma, and gastric carcinoma, G-junction adenocarcinoma, hepatocellular carcinoma, and urinary bladder cancer also. So these are the solid tumor trials, the name of the rationale, and some trial for the lymphomas are all ongoing. So the profile of tislelizumab, it has distinctive binding orientation, whether these few amino acids of PD-1 have identified as unique binding epitopes of tislelizumab. The binding surface of tislelizumab on PD-1 almost overlapped largely with that of PDL1, leading to complete blockade of PD-1 and PDL1 interaction by the more than 99% of patients, which was nearly 80% for the pembro or the nivo. So we are going for clinical evidence. First for NSCLC, the trial rationale 307, which studied this tislelizumab with the paclitaxel and carboplatin in comparison with the chemo only, with the stage 3B and beyond and metastatic disease not amenable for curative treatment without driver mutation and with good ECOG PS. It is open label randomized multicenter study for the metastatic squamous cell NSCLC. The primary endpoint of this study was the PFS, and the secondary was the objective response rate, duration of response, and the overall survival and safety profile. The most important thing is the crossover was allowed for the chemo arm on the progression to the tislelizumab. So the rationale 307 efficacy data both right and left arm came out showing there is a significant difference in the median PFS of delta of 2.2 months for the arm A versus C, and the delta of nearly 4.1 months for the arm B and C, with a significant hazard ratio of 0.45 and 0.43 on comparison. And this IO plus chemo arm showing clinically meaningful overall survival, objective response, and duration of response also in comparison with the chemo only. So, and the subgroup analysis for PFS, almost all patients showing good results showing favorable towards the tislelizumab. And we can see here the all patients with PDL positive showing positive results even more than 1%. In patients less than 1% also showing results favorable for the tislelizumab. But however, the confidence interval is large for PDL expression for less than 1%. And the OS subgroup analysis results as similar as in the PFS, showing better results towards the tislelizumab and the PC. However, there is a longer median survival follow-up of 44.8 months, which represents an additional 30 months since the final analysis. OS benefit with the IO arm was observed across most pre-specified subgroups, including all PDL1 subgroups with ECOG PS of 1 and stage 4 disease. These are the safety profile of rationale 307. There is no additional toxicity found with the use of tislelizumab. However, the immune-related toxicity which was common with IUs like skin reaction and hypothyroidism and pneumonitis, almost similar percentage as previous studies, but there is no additional toxicity on comparison with the and whatever the toxicity is noted, it is possibly because of the chemotherapy, like anemia, alopecia, neutropenia. And the conclusion of this, with 4-year follow-up, long-term survival after 4 years, tislelizumab with chemo achieved durable, clinically meaningful OS benefit versus chemo alone, and OS advantage remained consistent with final analysis despite of high crossover to tislelizumab monotherapy, and the survival improvement seen in the across all PDL1 subgroup, current and former smokers, stage 4 disease, and it is well tolerated with no new long-term safety concerns, and it confirms that tislelizumab with chemo as a promising first-line standard for advanced metastatic squamous cell NSCLC. So this is the part of 307 study, which they studied the role of tislelizumab beyond the progression of the disease also. So patients with progressive disease in the tislelizumab chemo arm were subdivided into three subgroups. Arm A treatment beyond tislelizumab beyond progression, and other OT group is switching to other anti-cancer treatment. There is those who not received any treatment after the progression. For post-progressive disease, OS and OS from randomization were evaluated in 3 groups. The post-progressive disease. OS in the patient with varying PD patterns. PD patterns like low risk, intermediate risk, or high risk. Low risk, those who have only progression in the existing lesions, or intermediate risk, those have progression only in the new lesions. And high risk, those who have both existing lesions and new lesions have progressed. So the results of treatment beyond progression is further subdivided according to these subgroups. So in 307, total number of patients were 360. Out of the 239 received the tislelizumab with chemo partner, and nearly 167.8% patient progressed. They further divided tislelizumab beyond progression in 40% of the patient, and nearly 34% of the patient treated with other anti-cancer drugs. Nearly one-fourth of patients not treated with any kind of medication on progression. So these were the baseline characteristics of further this study, and almost all comparable. However, the number of patients were more in the tislelizumab beyond progression. So results were median PFS was 9.71 versus 7.6 and 7.6 were other groups. And the maximum of the patient, the pattern of progression was found in the low risk of patients. Nearly two-thirds of the nearly 56% of the patient had low risk. So this is the median OS of progressive disease was 18.4 months for tislelizumab beyond progression versus 7.9 and 7.2 for other treatment or no treatment. And median OS from randomization was 28.6 months for tislelizumab. So, and further they divided this benefit in the according to PD pattern defined risk group. So results were better for both treatment tislelizumab beyond progression and the other treatment group for the low risk category where the existing lesion has progressed only. And there is no new safety signal observed during the tislelizumab beyond progression. And the conclusion of this, within the limitations of retrospective analysis, the tislelizumab treatment beyond progression might bring survival benefit for squamous and NSCLC patients after disease progression on the first line chemoimmunotherapy without increasing the safety risk. The patient with lower intermediate risk tended to have longer OS, suggesting a potentially beneficial population that needs further investigation and may offer insights for clinical decision making in the treatment beyond progression, and the finding need to be confirmed in the larger prospective study. One more real world study for advanced NSCLC containing both squamous or adeno, not amenable for the curative intent and with negative driver mutation. This is the real post retrospective real world study conducted at Sunlight Chest Hospital from June 2020 to April 23. And the patient were treated with tislelizumab monotherapy, and some patients with tislelizumab with chemotherapy. They are different with anti-angiogenesis and chemotherapy plus angiogenesis. The primary endpoint was the PFS and secondary was ORR, objective response rate, and overall survival. Out of 379 patient enrolled for the study is 376, and the maximum of the patient of 376, nearly 90% of the patients treated with tislelizumab with chemotherapy. And these are the baseline characteristics. If you see the histology, almost 50% of the patient of both histology, squamous and non-squamous, and nearly 60% patient of the smoker, and almost 55 to 56% were PD-L1 positive patient, and one-fourth of the patient was PD-L1 negative, less than 1%. So you can see here the there is good disease control rate of 97.9% with in this retrospective study with partial response of 56%. And here we can see the median PFS of the 12.9 months with 1 year, 2 year, and 3 year PFS rate of 55, 26, and 11%. And again, this subgroup analysis was done on the basis of the clinical stage, histological subgroup, and the age subgroup. According to clinical stage, there is no very much significant difference in the delta of only 0.9 months. And if we see by the histology group, so the non-squamous group did better than the squamous group. And if you see the age group, the elderly patient with their respective comparator arm did better. And we can subdivided the non-squamous versus squamous. Here we can see the non-squamous, the higher PDL1 more than 50%. Median PFS was 19.5 months, which was very much higher compared to less than 1% of the PDL1.
Sony, may I request you to wind up a little faster?
Yes, sir. Yes, sir. That's okay. So concluding this real-world study, the largest real-world analysis confirms tislelizumab-based first-line therapy delivers durable PFS across all subgroups, and the most important, most beneficial results for higher PDL1 for non-squamous NSQL. This is a similar kind of a study for the rational 312 for extensive stage small cell carcinoma, which also shows the median OS of 15.5 versus 13.5 months, IO with chemo versus chemo on, and very median PFS of 4.7 months versus 4.3. The subgroup analysis showing all the groups showing better results for the trastuzumab-based chemotherapy with chemotherapy, and there is no additional toxicity with on adding of IO. On concluding the 312, the long-term follow-up confirms the clinical meaningful and durable OS benefit with trastuzumab with chemo, and sustained OS improvement observed in the both ITT and PDL1 positive patients, and PFS also improved the ITT population. So findings reinforce the tislelizumab with chemo as an effective and safe first-line treatment in patients with extensive stage small cell lung. Thank you.
Thank you, Dr. Soni, to give the more insight about this new important molecule which has come in a big way in the first line treatment of the NSCLC and in the second line treatment of the squamous esophageal malignancy. Thanks to you. And it's now time for the learning with fun and with rewards, especially to the DNB and the DM students. And we have with us the well-known figure, Kaun Banega Karopati, the quiz master, Dr. Ankur himself from Ahmedabad. And let me thanks once again to Intas to organize this particular session. It's the quiz time for students based on the today's presentation. Yesterday we had the very interesting quiz conducting and by Dr. Ankur Shah. So today again, we hope that we will have the good things. We will be learning more and we will be judging ourselves that how much we have learned, concentrated on today's various presentation. So over to you, Dr. Emsa, and we have with us Dr. Mukesh Kumar Jandu, consultant medical oncologist from Service Health City Center, Hisar, Haryana. So he will be giving the final comments from after each and every question. And if any dispute is there, then probably he will be the final authority to make his final comment. So Dr. Mukesh, to you also.
Very good evening, sir. Thank you, everyone, for joining and participating for this quiz. Let's have some fun. To begin with, this is quiz 2. We had an exciting round of quiz yesterday. That was quiz 1. And the winners yesterday were Dr. Himansh on first position. Second position was Dr. Thanish. And on the third position, we have Dr. Balamani Kandan. So let's see who will be the winners for quiz 2 today. A warm welcome to all of you.
Dr. Ankur, sorry, can you tell us that from which place they belong, all these three yesterday's winner? Any idea?
No, sir, no idea.
So basically, I feel that organizers are the bad. They can.
We will just share soon, sir. So Naresh sir will soon. We will share on the screen.
Yeah.
Probably while they would have registered, they would have entered from which city and institute they are. Yeah. So shall we begin, sir?
Yeah, please.
Yeah. So all set. Let's start. So to participate this quiz, for the new joinees, I would like to repeat. Let's play Kahoot. There is an app called as Kahoot, Kahoot. Easy to download app. It would just take 30 seconds to download it. This is how it would look. I would request everyone to please participate with their full name. No nicknames, no initials. I repeat, please participate with your full name. No nickname, no initials. We will soon share the game pin and you can also log in by scanning the QR code on the screen. Allow us with few minutes. We'll soon share the game pin. There are 10 questions like yesterday. Today also there are 10 questions. Each questions will have 4 options. You need to choose right and you need to be quick. For the participants, they would have observed yesterday that all the 3 quiz winners had all the 10 questions right. But the difference was how quick you answer them. To score maximum, you need to be right and you need to be quick. That's the game pin on your screen, 3537201. This is the QR code. You can even log in with the QR code. Please log in with the full name, no initials, no nickname, please. I can see the excitement. There are already 13 participants who have logged in. So there were 3 quiz winners yesterday. First prize winner will get 21,000. Second prize winner will get 11,000. And the third prize winner will get 5,000. Today it is quiz 2, ESMO updates 2025. Today there are 3 more winners. There will be 3 more winners. Again, the first prize will be 21,000. Second prize will be 11,000 and third prize will be 5,000. 26 participants have already logged in. Slightly increase the volume, please. You can see Dr. Bridge, Dr. Dinesh Anand, Dr. Sai Kiran, Dr. Arvind, Dr. Maitreya, Dr. Akriti, Dr. Thanish is also participating. He was the quiz winner for quiz 1 yesterday, second position. We'll give you a couple of more minutes to log in. You get 45 seconds to answer each question. But to score maximum, you need to be right and you need to be quick. Each question will have 4 options, 10 questions to go. And with me is Dr. Mukesh, who will give comments post we see the answer on the screen. A minute more to go and then we begin. We have 27 participants so far. 28 now. 29. 'Last and final minute to log in. The game pin on your screen, 3537201. Okay, sir, if you could speak, then we would come to know you're audible or not. No, sir, you're not audible. Okay, sir, you're not audible. Yeah, Mukesh, sir, can you try once again? No, sir, we cannot hear you. No, sir, we cannot hear you.
So we can continue quiz. He will try to join you.
Yes.
Otherwise, we will continue rolling the questions in the interest of the time.
Yeah. There is one participant who has logged in with EH. Okay, let's start then. So let's begin. Kahoot quiz day 2. ESMO updates 2025. 3, 2, 1. Here we go. The first question on the screen. Which is true for phase 2 data CD19, CD22, bispecific CAR T cell therapy, CAR2219, relapse refractory large B cell lymphoma, complete response rate 67.7, cytokine release syndrome occurred in 74% with no grade more than or equal to 3, immune effector cell associated neurotoxic syndrome occurred in 6%, or is it all of the above? 20 seconds more to go. 31 participants have already punched in their answer. Ten seconds more to go. I repeat, you need to be right and you need to be quick to score the maximum points. And the right answer is all of the above. Over to you, Mukesh sir.
Yes, this is correct. Complete response rate range from 60 to 80%. It is average, and the cytokine release syndrome occur in approximately 80% of the patient, but it is mostly grade 1 and 2. And immune effector cell associated neurotoxic syndrome occur in 5 to 10% of the cases. Right.
Okay. That's the scoreboard, and it is led by Dr. Shubh, followed by Dr. Himanshu and Dr. Umar. Let's move on to the second question of the quiz. Which of the following BTK inhibitor is non-covalent type of BTK inhibitor? Ibrutinib, pirtobrutinib, acalabrutinib, or is it zanubrutinib? BTK stands for Bruton tyrosine kinase. 15 seconds more to go. We have 32 participants. And the right answer is pirtobrutinib. The house seems to be divided. Over to you, Mukesh sir.
Yes, this pirtobrutinib is the non-covalent. Non-covalent mean it is the reversible type of the inhibitor, and it overcome the drug resistance which come from the ibrutinib or zanubrutinib, like C487 mutation, which commonly come from these first or second generation drugs. So these come from the covalent, and the side effect profile is also less from the non-covalent type of the BTK inhibitor because of target toxicity is less from the pirtobrutinib.
Thank you so much, sir, for the explanation. Let's move on to the third question of the quiz. Before we do that, the scoreboard on the screen. Dr. Shubh was leading. The third question on the screen is NCCN guidelines. Which of the following is the fixed duration regimen for first line CLL, SLL without deletion 17p, TP53 mutation? Zanubrutinib, acalabrutinib with or without obinutuzumab, ibrutinib plus anti-CD20 map, or is it venetoclax plus obinutuzumab? The entire house seems to be divided, even though the majority goes with the option D, that is venetoclax plus obinutuzumab. Over to you, sir.
Uh, this is correct answer venetoclax plus obinutuzumab because in this trial CLL14 they compare with the chlorambucil with obinutuzumab and they saw significant difference in the PFS benefit, and this is the fixed duration regime in which obinutuzumab was given for the 6 months in first month day 1 day 15, and after onward once a month for the 6 month, and venetoclax was given for the 12-month duration. So it is the fixed duration regime, and all the BTK inhibitors are used with the infinity period.
Let's see the scoreboard. Dr. Shubh and Dr. Himanshu leads, followed by Dr. Bala Manikandan. And on fourth place, we have Tanish. Both Bala Manikandan and Dr. Tanish were the winners of yesterday quiz. Let's see Would we have a turnaround this time? Fourth question on the screen. Which trial compared ibrutinib and acalabrutinib in head-to-head study? Elevate TN, Elevate RR, Alpine, or is it Amplify? Easy to choose options, but I guess difficult question. 10 seconds more to go. Question is about which trial? And the right answer is Elevate RR. Yes, sir.
Yes, this trial was showing the side effect profile less with the acalabrutinib, and it is non superior PFS benefit was showing in this Elevate RR trial in which acalabrutinib was used.
Correct, sir. Can we have the scoreboard? And there is change in the scoreboard. With on third position we have Dr. Apurva. Let's move on to the next question. We are halfway through our quiz. The fifth question on the screen. Which of the following statement is not true regarding Alpine trial? Alpine trial was head-to-head study comparing zanubrutinib and ibrutinib. Alpine trial was done in first-line CLL. Zanubrutinib showed superior PFS compared to ibrutinib. Zanubrutinib had lower cardiac adverse events compared to ibrutinib. It's a tricky question. The question is, which of this following statement is not true? Be very careful while you choose. And the right answer, even though it's not true, is Alpine trial was done in first line CLL.
Yes, both as well as in previous trial, Elevate RR and this Alpine trial, both trial was done in the relapse cases of refractory cases of the CLL.
Correct.
In this trial, it's showing superior PFS benefit, while in previous trial, acalabrutinib was not showing. So that was a non-inferior trial.
Okay. Let's move on to the next question. No changes in the scoreboard in top 3 position. Sixth question on the screen. All of the following TKIs used in CML are dosed once daily, except imatinib, nilotinib, dasatinib, bosutinib. TKI stand for tyrosine kinase inhibitors in CML, chronic myeloid leukemia. The question is except. The right answer is nilotinib. Rest are dosed once daily. Nilotinib is not. Over to you, Mukesh sir.
Yes, very easy question. Right answer was done by approximately 17. Next.
Yes. Moving on to the next question. We have changes in the scoreboard. We have Dr. Sai Kiran on the third position now. Dr. Shubh and Dr. Himanshu continue to lead. Yes. Let's move on to the next question. The seventh question on the screen. Which of the following statements are true? Durva after CCCRT, that is concurrent chemoradiotherapy, is standard of care, unresectable stage 3 NSCLC specific. Skyscraper 03 tested tiragolumab plus atizo versus durva as consolidation therapy. The participants looks quite confident while they answer it. In fact, before I could finish reading the options. The right answer is all of the above. Statements are true. Mukesh sir, your comment?
Yes, sir. This one is the negative trial and recently published in ESMO 2025.
Okay. Let's move on to the third last question of the quiz with no changes in the scoreboard. Third last question on the screen. Which of the following statements is not true for North Star trial in NSCLC? It was a phase 3 study. The trial was compared with osimertinib plus local unifying therapy versus osimertinib in EGFR mutant advanced metastatic NSCLC. Osimertinib plus LCT improved PFS compared to osimertinib, or is it the benefit of LCT on median PFS was observed across subgroups? LCT stands for local consolidative therapy. And the right answer is it was a phase 3 study. But it was not true when it comes to North Star trial in NSCLC. A tricky question. Over to you, Mukesh sir.
It was a phase 2 study in which approximately 42 patient was taken, and the trial compared with the osimertinib versus osimertinib plus local consolidative therapy with RT. After 2 months, on the basis of the response that where we have consolidate with the RT, and this showing approximately 7 to 8 month PFS benefit from 17 month to 25 month of PFS benefit was seen.
Going on to the second last question of the quiz. But we have a change in the scoreboard with Dr. Manoj on the third position. Second last question of the quiz. Participants, please buck up. Which of the following trial was done? Adjuvant treatment for patients with resectable ALK positive NSCLC. Comparison was done between alectinib and crizotinib. Alectinib induced clinically meaningful OS benefit compared with crizotinib. Or is it OS benefit with alectinib observed with CNS mets at baseline? The question is, which of the following statement is false? To be right, you need to choose a false statement. And the right answer is trial was done adjuvant treatment for patients with resectable ALK positive NSCLC. Yes, Mukesh.
This trial was Alex trial was not in adjuvant setting. It is basically in metastatic or advanced setting, and OS was benefit was seen. 5 year OS benefit was seen. Approximately 17% difference of the 5 year survival benefit from 45% to 62% difference at the 5 year. And this drug is the having CNS penetration, so it also show benefit in case of the CNS disease also.
Yes.
On the basis of this, this was further tried in the adjuvant setting.
Let's see the scoreboard. Does Dr. Shubh still leads? Yes, he still leads, followed by Dr. Himanshu and Dr. Manoj. Let's move on to the last and final question of quiz 2. Let's see who will be the winner today. Which ALK inhibitor is approved by FDA for adjuvant treatment following complete tumor resection in ALK positive NSCLC? Lorlatinib, alectinib, ceritinib, or is it crizotinib? Last and final question. Will Dr. Shubh be the winner for quiz 2? ESMO updates 2025. 10 seconds more to go. Exciting prizes. Who takes away them? And that was quite quick. And most of them have answered it right. And the right answer is alectinib. Yes,
Yes,
sir.
definitely based upon the ELENA trial, this drug was used for the 2 year and 600 mg dose for the 2 year. Base first results come basis on the EDURA trial. They show that there is a meaningful difference when EGFR mutated based upon the osimertinib. Then another, if there is ALK mutation was present, then this drug was tried in the adjuvant setting from the stage 1B onward for the 2 year. In those cases, there is a meaningful difference in the disease-free survival, and there is a basic unmet need to improve disease-free survival, because when the disease come in after adjuvant treatment, it most of the people develop metastatic disease, which is not controllable, because ALK positive have higher metastasis tendency in the CNS also, when then patient become palliative. So our we all are in more inclined toward the adjuvant use of these targeted drug, so we can increase DFS.
Yeah. Thank you, Dr. Mukesh, for your comments
Thank you.
on each and every question. I am sure that participants would have learned a lot from this. So let's see the scoreboard. Who will be the winner for quiz 2? ESMO updates 2025. And on third position, we have Dr. Manoj Sharma. On second position, we have Dr. Shubh. Oh, that's a turnaround. So who becomes the winner? The winner is Dr. Himanshu. He gets 9 out of 10 correct. In fact, second and third position also have 9 out of 10. So the difference Dr. Himanshu would have done is he would have answered this one faster than Dr. Shok. Congratulations, winners. The winner at first position gets 21,000, on second position gets 11, and on third positions get 5,000. Congratulations.
Many
I hope everybody would
congratulations
have
to
enjoyed.
Dr. Himanshu, to Dr. Sob, Dr. Manoj Sharma. Many congratulations to all three, and all also who participate in the quiz, because participation is the main thing.
Yes, 32 participants today as well.
Okay,
Dr.
very
Naresh
nice.
sir, your comments?
Yeah, thank you, Dr. Ankur sir, for conducting nicely over the 2 days. And thanks to Mr. Vivek Mishra from Intas to supporting this particular event. And thanks to Dr.
Thank
Mukesh
you, sir.
Jandu
Thank
from
you.
Hisar to make it in authoritative way. And before we conclude this ESMO over the 2 days, let me thanks to all the participants, all the students, all the faculties, guest speakers, as well as all the sponsors who helped us to design, to arrange the various presentations, literature, and helping out to conduct this meeting smoothly, fifth consecutive year. And with this, once again, thanks to all. And thanks to the team Horizon, Mr. Tarun Mathur, for making the things in a beautiful way and taking most of the burden from away from my shoulders so that it could become in a perfect way. And I can see here the name Dr. Himans, Dr. Thanish from Chennai, and Dr. Balamani Kandanam from Coimbatore. So congratulations to all of you and to the yesterday's winners also, and hope to see you soon again in some meeting, maybe physically, maybe in the form of the virtual meeting. Till then, good night. Bye bye. Stay safe. See you soon.
Thank you.
Any comment from Horizon side?
Thank you, sir.
So thank you so much, Dr. Somani sir, for always giving this great opportunity, and thanks to the entire colleagues, everyone. On behalf of my
Thank you, sir.
colleagues,
Thank you.
Geetika and Jhalak, it's been 2 day wonderful journey, and of course, from all of you, we say thank you, goodbye, till we meet again for the next episode. Thank you so much, and we request the team to please close the webinar. Thank you so much, and good night, sir.
Thank you.
Yeah. Congratulations, everyone, for the successful program. Thank you.
Thank you. Thank you, Dr. Anand. Thank you all.